morning to members of the public in attendance. We're glad that all of you can be here with us during today's meeting. At this time, I call the meeting to order and ask Vice President Forsyth to take the roll call and establish a quorum.
Dr. Morrow?
Here.
Forsyth here. Steve Afriat? Burton?
Here.
Chappelle Ingram?
Here.
Dawson?
Here.
King?
Here.
Lai? Here. Lay? McKenzie? Here. Stewart? Here. Witcher? Here. And Wu. Oh, here. We have a quorum.
Thank you very much. I want to ask at this time for all of us to please turn off our cell phones or put them to silent mode and make sure that they are not on the table in case they vibrate and we get some strange sounds over the PA system. You may notice that board members occasionally are accessing their laptops during the meeting. They are not using the laptop. They are using the laptop solely for access to the board's meeting materials that are in electronic format. This meeting is being webcast and will be archived after the meeting and available on the board's website for viewing at a later date. This is an official meeting of the Dental Board of California. We have a designated time on the agenda for public comment and ask for public comment on each agenda item. Each person will be limited to 3 minutes per agenda item. The board welcomes public comment on any item on the agenda, and it is the board's intent to ask for public comment prior to the board taking any action on any agenda item. If, for some reason, I forget to ask for public comment, don't be bashful or shy, but raise your hand and I will recognize you and you will be able to speak and give your comment. I want to remind all speakers to please stay on topic and to keep your comments to 3 minutes or less, and I thank you for your cooperation. Also, I think it's important that we keep in mind that the protection of the public shall be the highest priority for the Dental Board of California in exercising its licensing, regulatory, and disciplinary functions. Whenever the protection of the public is inconsistent with other interests sought to be promoted, the protection of the public shall be paramount. Moving to agenda item number 16, the Executive Officer's Report.
Good morning, everyone. My name is Karen Fisher, and I'm the Executive Officer of the Dental Board of California. I'm going to start my report this morning with a staffing update. As we've mentioned throughout the day yesterday, in looking at our statistics and considering the workload, you can see a detailed report here. We've had a number of turnover this year. We seem to get fully staffed, and then we have people retire or go on to promotions in other places. I think Ms. McKenzie had asked a specific question about the complaint and compliance unit, and I think that you'll see in my report here that we're nearly full. In fact, I think we probably are as of most recent. So those positions have been filled, and we're conducting the training in order to bring people up to speed, and we'll be able to continue to process our complaints efficiently. I think it's pretty self-explanatory. The exciting thing for me, aside from filling our vacancies that we have, is that we're finally getting our full complement of a management team. During my 4 years as executive officer, I'll say it's been challenging to essentially start my tenure without an assistant executive officer and then transition into enforcement chiefs and other managers all retiring out at the same time. So it's an exciting time for me and our staff in order to bring people on who are enthusiastic, who are bringing information and experience from other places to help us build a strong management team once again, and to look at our processes and see whether we can do things more efficiently and effectively. I'll move on past the staffing report unless any board members has a specific question. I'll draw your attention also to the Orange Field office on page 2. We have 4 vacancies now. 3 of them are nearly filled, and one of our seasoned folks decided to leave and go to another organization where he'll be making more money. So while he loved working for the board, he couldn't pass up a promotion moving on. So we hope to be filling those positions quickly. An update on the Republic of Moldova Dental School application. The site team is ready to go to Moldova. All the appropriate approvals have been made. The date is scheduled for October 1st through the 8th. Dr. Morrow, our board president, also our faculty member on the board, will be heading up the team of Dr. Timothy Martinez and Dr. Octavia Plesch. I will not be going. We are sending a staff person along who will be the scribe, and it's going to be a pretty rigorous trip. While the trip is actually 8 days long because of travel back and forth to Moldova, the actual site visit will occur at the facility on a Monday, Tuesday, and Wednesday. The site team will then, on Thursday, essentially write the draft report and then head home on Friday. So we'll be looking forward to hearing the results of that site visit, and we'll be seeing their report coming soon. Also in your packet, are there any questions about the site team going to Moldova? Okay. The update on the Controlled Substances Utilization Review and Evaluation System. At the end of the day, I'm going to send out a little quiz and say, what does CURES stand for? So I think we all agree we know at this point, so thank you for memorizing that. I continually have to remind myself. But the requirement for dentists who hold a DEA license as well as an active California license to register for the CURES program, the deadline was July 1st. And we are working with the department and the Department of Justice to find out whether we can know how many licensees have yet to sign up to register for CURES. The board does not have the information on which of our licensees have DEA licenses. So it will be an effort on Department of Justice and the Department of Consumer Affairs to try to see if we can determine how many of our licensees actually have DE licenses and should be registered. So we continue to assist people. If anybody does have questions or concerns about having difficulty signing up for CURES, please call me. We will have staff walk them through the process and see if we can help them through it. At the May board meeting, one of the board members asked for additional information following Dr. Morrow's report on the snapshot of dental education nationally. And so in your packet is a breakout essentially of ethnicity by school. I'm not seeing the member that asked for that to be included in the packet here, so we won't, unless somebody has any further discussions, I'm not sure what his specific questions were relating to this information. So unless you have any further questions, it's there for your information just as follow-up, as a board member had asked it be included in the packet. As you will recall, a representative from the California Society of Periodontists requested that the dental board endorse its efforts for the creation of a periodontal disease awareness month, otherwise known as Gum Disease Awareness Month. I actually will be working with the executive director of that organization. Laura Purcell is here. Welcome, Laura. She and I will be working together to bring further information back to the board meeting in December. So that was another follow-up of an open item. Just wanted to report that also effective July 1st of 2016, our licensees, dental assistants, EF assistants, dentists were all required to submit their email addresses to us. I'm happy to report that we have gotten a very good response, but I also want to let you know that staff We'll be sending out an insert in the renewal notices, reminding all licensees of this requirement, and staff is collecting emails at every opportunity, including if they're talking to somebody on the phone about a different issue, they're asking whether or not they've submitted their email address and then taking that information down. Staff will also be attending the CDA Presents in September. There will be a booth there, and we'll be collecting email addresses at that time too. So if you're going to be attending that, stop by the booth, give a shout out to our staff who will be answering all kinds of questions, and we're looking forward to that, participating in that event. Answering the phones, we're getting good news and bad news about whether the phones are being answered. Oftentimes we get, I get notices from consumers and licensees who have been very happy with the service that they've received from the dentist. And then now and again, we still get people who've said that they have difficulty getting through. It's an issue that we're going to continue to work on, and as we're getting fully staffed here, hopefully we'll have better results that I'll be able to report in December. Lastly, I think that one of our members had asked for an update on Section 1115 of the Medicaid waiver. I hope that that was covered yesterday with Dr. Kumar's discussion. If anybody has any additional questions on that particular issue, Dr. Kumar is available to answer any questions, and we can get you in touch with him. Lastly, I just wanted to reiterate what I mentioned yesterday, that there are a number of board members whose initial terms will be up at the end of the year. I will be contacting you to ask if you're interested in having a second term, which I hope all of you will be interested in having a second term. The requirements that the governor actually asks for is he'll be asking me for your attendance records, whether or not you're participating and contributing to the discussions, and whether or not you're fulfilling your obligations as a board member and in good standing. I accept dark chocolate, flowers. Not really, only kidding. Oh, no wine. That concludes my executive office report.
Thank you very much, Karen. Do any board members have any questions or comments relating to the executive officer's report? Okay, hearing none. Do any members of the public in attendance have any comments or questions regarding the executive officer's report? Okay, moving on to agenda item number 17, a report from the Dental Hygiene Committee of California.
Good morning.
Good morning, welcome.
I'm Noelle Kelch, the president of the Dental Hygiene Committee of California Board, and I wanted to come before you today to bring you greetings. I also have to my left our executive officer, Lori Hubble. We have some exciting things moving forward with the Dental Hygiene Committee of California, and we really want to thank the Dental Board for being part of the things that have moved forward this past year and the years previous. First of all, we're going to be putting together our second strategic plan, which is kind of an exciting event for us. In reviewing our previous strategic plan, we have brought forward many things over these past years. The second thing that I wanted to really say thank you for was the infection control. This year we'll be meeting as a committee again to go over the infection control guidelines and to see what needs to be changed with the new documents that came out from the CDC this past year. One of the exciting things in going over those documents was that California was ahead of the game here. We've had, for example, hand pieces and the motors with hand pieces need to be autoclaved, and we were one of the first states to bring that forward. We now have 11 states that it's in their Dental Practice Act, which is really exciting, and the new document that came out really reiterates how important that is. We were also one of the states that first said, we want you to have utility gloves on when you're working with sharps after patient care and with chemicals, and that is now in the guidelines and is very firm and strong. It's wonderful to be able to look at these new documents. There's a great checklist that comes with that, and I'm looking forward to when we have that committee meeting and bringing this forward. The next part that I wanted to bring you greetings about was that Breeze is turning into a little bit more than a breeze right now. The storm is passing quickly, and I just want to commend my staff for all the extra hours and manpower that they have put in. I used to get a lot of phone calls about breeze, and now it's getting fewer and fewer. It's kind of like we're getting to the drought season to match the rest of California. The next thing that we've been working on as a committee is the events for out-of-state. Some people didn't understand some of the out-of-state people that come into California that wanted to come in as volunteers, and we wanted to make sure that we were keeping the consumer safe, so we're modifying those regulations and making people aware that are giving these events, that people that do come out of state, that we welcome them, but there is a process for them to come and volunteer within the state. And we wanted to encourage the dental board to also look at theirs and make sure that everyone has a general understanding of what has to happen before you can volunteer at those events. In this, as of tomorrow, we have a special meeting that we pulled together very quickly. You'll see that we're meeting here in Sacramento. And the reason that we're having to do that is we had to deal with a very important immediate concern on hygiene education. We had some complaints from students and faculty, which resulted in an investigation, and we're looking forward to resolving that quickly and keeping the consumer safe. And we wanted to say thank you to the dental board for how they've helped facilitate some of that process so that we can make sure that people are kept safe. We look forward to working together on the cooperative in developing curriculum for ITR, and are looking forward to getting those meetings moving forward so that we can make sure that we are working together to create that curriculum. You know, one of the things that's been wonderful this past year as president is to see the cooperatives that happen within the dental board and the dental hygiene committee, and I really want to encourage us to continue that. As I've gone over enforcement issues, as I've looked at the diversion process, without you, we couldn't be doing some of these things, and that cooperation, working together and seeing that happen successfully, I just want to say thank you for everything that you do on your end, and how we can have two structures working together for the same cause, which is to keep the consumer safe. Thank you for allowing us the time to share what we're doing, and thank you for what you're out there doing.
Thank you very much for that report. And I also want to express my appreciation for our collaborative efforts in the past and look forward to continuing that relationship in the future. Any comments or questions from members of the board regarding this report?
I just wanted to add thank you, Noel and Lori, for attending the meeting. Board members just need to know that there are times when, because the hygiene committee is small, they are building their enforcement program, and they sometimes need assistance with our investigators to go in and help with some projects. And so we're happy to offer that help, and hopefully that is helpful to you. I'm sure it is.
Well, the professionalism and the immediate response is amazing. And I know that you've had problems with your phone system. I do have to tell you, as I've talked to consumers in the field and I've talked to people, that has been changing, and I just want to commend you for that, too.
Thank you. Thank you.
Thank you very much. Any comments or questions from members of the public in attendance relating to this report? Okay, with none? Thank you very much. Okay. Moving on to agenda item number 18, subcommittee's report regarding the progress of the pediatric anesthesia study. Board members, Dr. Bruce Witcher and Meredith McKenzie, will lead out in this discussion.
Thank you. I'm going to do my presentation from the witness table there. Just a couple of opening comments. You've all received the report that we have prepared. It's a draft report. It is a work in progress. Moving forward, and I'll go into this a little more in the discussion, we'll be taking additional input. For purposes of today's presentation, I'd appreciate it if people would hold their questions to the end. We'll follow the presentation with board member questions and discussion, and then we'll open it up to public comment. Okay? I'll go ahead and get started.
And I just wanted to let the public know that there, I think, are additional copies of the working document back on the table.
They will be about that table.
Okay.
Mary?
Can I just ask, isn't this the packet we got online, on our computers, so we could hand over ours if we have it? Okay.
If somebody could hit that sconce lighting, that would really help. Okay, I'd like to go ahead and get started. For those of you who don't know me, I'm Dr. Bruce Witcher. I served on I'm a board member and served on the subcommittee to prepare a draft report on pediatric anesthesia. This was done following a request by Senator Jerry Hill. Ms. McKenzie, who is my co-committee member, is here with me today. In opening, I'd just like to say it's always a little intimidating presenting in front of peers and colleagues, many of whom are experts, renowned experts in this field. So, I'm going to try my best to get through this. And then the goal of today's discussion is just to hit the highlights, do an overview of the report. There's a lot of information there. There is no way I can go into detail on all of it. Also, I hope you will leave with a little better understanding of some of the issues that are being discussed and how some of these things actually work in practice. So basically, Pediatric Dental Anesthesia Study Working Draft, as most of you know, you've probably had a chance to look at it. We did present this at a workshop on July 28th. We had really good stakeholder participation there, and we were very pleased. We received a lot of input, and that was a very positive discussion. The working draft includes background of the Dental Board of California, comparison of California laws, regulations, and policies with those of other states, a comparison of California laws, policies with association guidelines, a review of the relevant medical and dental literature, and finally, some statistics prepared by the enforcement unit of the board. The subcommittee actually did not participate in that aspect of the project. That was done entirely by board staff and the consultants, of course. The working draft, as you will have noticed, and we remarked on this at our workshop, also does not include recommendations at this time. Moving forward, we will develop a final document that's a finished document, no longer a working draft, that will include stakeholder input and recommendations that will allow the board to improve the safety of pediatric anesthesia in California. We will be having additional opportunities for stakeholder input moving forward. It's really up to stakeholders to let us know what format they would like that to be in. We will certainly make ourselves available for those opportunities. As most of you know, I think the final report will be released in advance of the December 2016 dental board meeting, and the final report will need to be approved by the board, and then it will be submitted to the legislature in January of 2017. We have received stakeholders' comments to date, as I've mentioned, both by email, hard copy, and some of the comments were submitted at meetings as verbal testimony. These are the major organizations that we have received input from, and also a list of the individuals. Unfortunately, time does not permit me to review all the comments that have been submitted. However, we have compiled those and will be distributing those to all board members for their review. So the history and function of the board, I think most of you are aware. The board was created by the legislature in the 1880s to regulate the practice of dentistry, and the definition of dental practice is listed in Business and Professions Code 1625, and it includes the use of anesthetics, drugs, and physical evaluation for purposes of dental treatment. And this actually goes all the way back to the very invention of anesthesia by dentists in the 1840s. So the association between dentistry and anesthesia is a very long one. The mission of the dental board, as Dr. Morrow described, is protection of the public. This is our paramount concern at all times. Let's start off with some definitions. These are in the draft report. I'm not going to list these specifically because they are available to you, but what we're talking about here during this discussion are minimal sedation, moderate sedation, known in our laws as conscious sedation, which we believe is an outdated term, deep sedation, and general anesthesia. And again, around the year 2000, new definitions were published by the American Society of Anesthesiologists, and I'll talk a little bit more about how those have affected various state laws, guidelines, and other documents. But the underlying concept here is sedation is a continuum. It is not always possible to predict how an individual patient will respond. Practitioners of sedation must be able to rescue the patient from the next deeper level should the patient enter a deeper level of sedation than intended. Now, here is a list of our anesthesia laws in the state of California. I'm not going to ask you to memorize this slide or take notes on it. This is all in the working draft, and it just shows that they're in a lot of different code sections, and to get an idea of what is really there, you do have to kind of hunt them down a bit. But during our review in the working document, how these are applied and what they specify in each section is described. For purposes of comparison with laws in other states, we broke these down into categories. We used roughly 9-10 categories and did a side-by-side comparison using Excel spreadsheets. Compiling all the information from state laws around the country was quite difficult. We used a lot of secondary sources. Where necessary, we did go to the code as published on the Dental Board website. We ran into a few instances where a legal opinion from that board would probably be necessary. So again, this is a rough approximation of what's out there. And so these were the areas of comparison. We found California dental sedation and anesthesia laws are very similar to laws in most states. The exceptions being a lot of states have adopted the ASA levels of sedation definitions. California has yet to do this, although that has been on our list of priorities for a number of years. There are variations in moderate oral sedation educational requirements between other states and California, and we'll talk a little bit about that. The personnel requirements that are specified in other states vary some, and this has been a subject of intense discussion, and so I'll go into this in a little bit more detail. And then many states have preoperative fasting instructions that are specified at certain times and so on. California does not have specific requirements in this area, and we'll take a look at that. So speaking about moderate oral sedation education, again, this has been a popular approach. We have approximately 3,000 people in the state of California who hold various oral conscious sedation permits. There is one for pediatrics and one for adults. The education approach taken has evolved over time. You'll see two kind of medium bars on the left with sevens above them. Those are states that have adopted more or less the American Dental Association educational standards that involve 24 hours of education and completion of either 3 or 10 clinical cases. And I'll refer you to the ADA guidelines for the specific of that. California presently requires 25 hours of instruction and completion of 1 clinical case. There is a trend indicated by the tallest bar there, there's a 16 above it. That indicates that the training for oral conscious sedation has moved towards 60 hours of education and completion of 20 clinical cases in a number of states. And I believe the reason for this is that there is recognition that levels of sedation produced at the moderate sedation level are really the same regardless of route of administration, whether it's given orally, whether it's given IV, intranasally, intramuscular, by any number of routes. And so the thinking here is that moderate sedation is moderate sedation regardless of route. And so the standards for education and the standards for regulation should be the same. And so this has been a trend ever since this concept first came out at the ADA House of Delegates a few years ago. As states have updated their laws, some have incorporated this, others have not. Let's talk about pediatric sedation as we found it around the different states. This is the subject of our report, so I would be remiss in not including this. Pediatric patients are defined by age at different ages around the country. California, it's 13 and under. Probably the most common is age 12 and under. That's the age that is recognized by the American Dental Association. Pediatric sedation permits are now issued in 9 states. This is a new development. It used to be that maybe there was a pediatric oral conscious sedation permit like California, but that was all. But now we have much more comprehensive and much more specific pediatric sedation permits that specify additional hours of instruction specific to pediatrics and completion of pediatric cases. And I'll give you a slide that goes into more detail here. Again, some states have chosen to address pediatrics by including specific training for pediatric sedation. This usually includes pediatric adult life support, advanced life support, or the PALS course, and 20 states presently require PALS. California does not, and I think one reason is among sedation practitioners, PALS is recognized as perhaps not being the ideal course for management of sedation-related emergencies. Pediatric oral conscious sedation requirements exist in 29 states, and you'll see this in the next graph. These are mainly limited to requiring appropriately sized equipment for the administration of pediatric sedation. So here's again what we found in the distribution around the country. On the left, as I said, that's usually pediatric sedation equipment, and these numbers are not exact. It's scaled there just to show you the kind of the range of things that are going around the country in this field. We see there's pediatric sedation permits. Some people follow the ADA guidelines. California, again, is 25 hours instruction in one clinical case. And these range from no training requirement in some states at all the way on up through requiring pediatric dentistry residency. So it just shows that the states are still trying to figure this out. Personnel, again, as I mentioned, this is an area that has generated a lot of discussion. In California law, as it now stands, patients must be monitored on a 1-on-1 ratio by the dentist until fully recovered. Other states have gone farther and specified a number of staff that is stratified according to level of sedation. The most common is 2 persons in addition to the dentist for general anesthesia and 1 person in addition to the dentist for moderate sedation. And this comes from the ADA guidelines, and I'll talk a little bit about that. And you'll also notice there's a lot of overlap between laws in various states and professional guidelines. States frequently will borrow from other states, borrow from professional guidelines when they're drafting their sedation laws. So there's going to be a lot of commonality and some overlap, so some of the things may seem a little repetitious because they appear in both documents. At present, approximately 29 states now require a designated anesthesia monitor. This is a newer phenomena. This is a dedicated assistant that monitors the patient undergoing sedation or anesthesia, and 14 states further specify the training for this staff member, which is usually a course offered by one of the associations. So let's talk a little bit about how this model actually works in practice, and it turns out there's a couple of models within dentistry. And so I think many of you may not be familiar with how this is done. You know, it's a small community of people who practice this way, and so I thought I would add a few slides and kind of try to communicate what is actually done. So the dominant anesthesia or sedation delivery model in North America and the 50 states in Canada is known for dental anesthesia or sedation is known as the team model. This consists of a dentist with an anesthesia permit who has to meet certain requirements to be given that permit, with 2 trained assistants monitoring the patient as a team, performing the surgery, and administering the anesthesia. So what we see is at the head of the chair there, we have 1 assistant. That would be the designated anesthesia monitor. She watches chest wall movements, checks to check the breathing, watches the monitors that are, that's chest wall excursions there, okay, checking ventilation. She's checking ventilation and respiration, looking at the monitor that's placed in a location easily visible to all team members. The second staff member assists with the procedure. The dentist usually uses a precordial stethoscope, and I'll describe that in a subsequent slide. The third staff member is generally available as a circulator to come in and assist in the event of an emergency. As it is currently utilized, the team model is used primarily for brief interruptible procedures, which are most of the things that we do in dentistry. In other words, in the event of some kind of problem, the surgery can be terminated immediately, and the airway managed or whatever complication has been encountered can be dealt with. It's generally used in healthy patients. If we have a really elderly or ill patient, usually we will use more of a local anesthetic or moderate sedation technique, or if they truly need a general anesthetic, they'll be done in a higher level of care facility. Let's talk about monitoring. We're throwing all these terms around. I realize some of us may never have actually had to look at a patient monitor. This is a multifunction monitor. They're found in all kinds of care settings where sedation is given. They become very common in dental offices that do sedation. On the top trace here, you have your electrocardiogram or ECG. This displays the electrical activity of the heart and allows evaluation of the rate and rhythm. You're looking for changes in rate or irregularities. There's also a pulse oximeter. I think most people have heard of that. That is required for all levels of sedation in California. There's also here a capnograph waveform trace. Capnography measures the exhaled CO2 generated by the patient. It's an excellent monitor of both ventilation and respiration. And so each one of those waveform traces indicates a breath. So this gives you real-time breath-by-breath monitoring. And I think most of the practitioners who utilize deep sedation or general anesthesia are using this type of monitor. It's just extremely useful, and technology has really kind of come to the fore and helped us out with this. We also have an automated blood pressure cuff that gives readings every 5 minutes. That is required by California law. And this unit, of course, will print out a printed record of the entire procedure and all the parameters throughout. And so that's a useful bit of evidence to have in the chart. The patient's breathing is checked by listening through a precordial stethoscope. So the dentist is in touch with the patient, listening to airway sounds at all times, verifying that respiration is as it should be. And as I've mentioned, the procedure may be stopped immediately if any abnormality is detected. And you have to kind of see the team in action to understand how this all works, because if you have a competent team working together, airway, breathing, and circulation are monitored at all times. Let's talk a little bit about emergency management. What happens in the case of an emergency? Well, it's usually an airway emergency. And in this case, the dentist will take over management of the airway and do the triple airway maneuver and some other things that you do initially to assess airway patency. And if necessary, apply positive pressure ventilation and direct the team to assist him by drawing up medications. Our team members, our 2 assistants must be trained in basic life support along with use of the AED, so they may perform defibrillation, and usually additional staff members are called in to assist, obtain vital signs, and record events. So again, there are some assumptions for this to work effectively. First of all, the dentist must absolutely be competent in all aspects of airway management. California law requires a holder of a general anesthesia permit to be able to deal with all airway complications from airway obstruction all the way up through emergency tracheotomy if there's a can't intubate, can't ventilate kind of situation. Competency is furthermore verified by the office evaluation, and that is used to assess the entire team. In other words, during the office evaluation and inspection that must occur every 5 years, the team is put through its paces. I'm getting a message here. And so competency is therefore verified during the evaluation. And these competency evaluations come to board staff. They're graded on a pass-fail basis. I think some people are familiar with them, so I won't go into that too much. So here's another provider model that is also used widely in dentistry. This is the 2-provider model. I mean, there's a lot of terms for it, but what the key here is this utilizes a dedicated anesthesiologist and a dentist who is trained in basic life support, and an assistant who should also be trained in basic life support. Some dentists would be trained in advanced cardiac life support as well. It just sort of depends on their background, but it's not required. The anesthesiologist will have undergone a dental board office inspection and evaluation if he has a permit in the state of California. And this anesthesiologist, he may appear to be staring out into space, but actually he's doing what all good anesthesiologists do. He's looking at his monitors, and he actually has a breathing bag in his hand, so he's monitoring the patient breath by breath. Now, in this case, the patient actually has a breathing tube, and so he is somewhat remote from the patient. Excuse me. And this allows the dentist to freely carry out their procedure. In the event, this is the 2-provider model that's most often utilized under the current regulatory scheme for small children, high-risk patients, lengthy or complex procedures. And of course, the other possibility is to utilize a higher level of care facility, such as an ambulatory care center or a hospital. And in the case of an emergency, the anesthesiologist manages the emergencies and directs the dentist and other associated staff to perform BLS and assist him in management of the emergency. So similar to the previous model, what we have is we have a trained anesthesia provider who is skilled in airway management and management of resuscitation with ACLS, verification of skills through a permit, and 2 trained staff members, or a staff member and a dentist, who are trained in BLS or higher level training if possible. So now that you have a little idea of what we're really talking about here, I'll move through the rest and I'll try to be brief. So our next move was to compare California laws with professional association guidelines. And again, we use the same categories, and you will notice in Appendix 2 of the document, there's a side-by-side comparison between California laws and what I would call the dominant guidelines. California law is generally consistent with professional association guidelines, but there are some inconsistencies, and they're similar to the inconsistencies with state laws, and so we'll go through these. So probably the most widely recognized guidelines within the dental profession anyway are the American Dental Association Guidelines for the Use of Sedation and Anesthesia by Dentists, last updated in 2012, and this has been going back and forth between the originating committee and the House for a few years, and it's supposed to be updated again this year. Also, there is a companion document known as the Guidelines for Teaching Pain Control and Sedation to Dentists and Dental Students. And this is basically the educational standards. These do not deal with education for general anesthesia deep sedation. These guidelines refer to the Commission on Dental Education Standards for Accreditation of Advanced Residency Programs. That is in an attachment to the report where all the CODA standards are printed out, and you can compare those as well with what's available in California law. We also have the American Academy of Pediatrics, American Academy of Pediatric Dentistry document. These are the guidelines for monitoring and management of pediatric patients during and after sedation for diagnostic and therapeutic procedures. These, in their present form, they were first published around 2006. Updated in 2011, and now we have a new version that just came out late last month. And so some of this report needs updating because it was done prior to release of that document. The American Dental Association support these guidelines for children age 12 and under. The ADA guidelines really kind of have a cutoff at age 12, and for instance, their educational standards don't really go into training for pediatric sedation, even for pediatric oral sedation. So that is why states have had to develop their own standards. One thing I would have to say about these documents is they're called guidelines. They aren't really true guidelines in that they're not truly evidence-based, in that they're based on a literature review and expert opinion, which has been that way for a while. They do not grade levels of evidence. There is not, and some of the documents that I'll mention actually use that approach. And I think that's sort of an evolving standard. It's used more in Europe than it seems like in the US. Okay, Professional and Medical Association guidelines. Some of our stakeholders asked us to take a look at their guidelines as well. The American Academy of Pediatrics, of course, has the joint document put out by the American Academy of Pediatric Dentistry. The California Society of Anesthesiologists submitted guidelines for us to review. There are a number of these. These are just a few, and I'll kind of hit on the salient points, but we did go through all of them. And I'm sure representatives of the CSA and various associations will be here to tell us more about their guidelines. First, monitoring. This is an area where California deviated from some of the monitoring standards, and I'll go through these now that you know a little bit about what these different monitoring modalities are. California law requires a dentist to possess an ECG monitor if general anesthesia is given. However, it is not required for moderate sedation. The ADA guidelines indicate that it should be considered if the patient has moderate cardiovascular disease. ECG is required for a patient receiving general anesthesia under ADA guidelines. In other words, the ADA guidelines differ in that they actually say this must be used, whereas some of the other guidelines just say that it has to be available. The AAPD guidelines, for instance, say an ECG monitor should be available. The monitoring standards from the ASA, they have a document known as Basic Monitoring Standards. They indicate that an ECG should be required for all patients undergoing sedation or anesthesia. So again, even within the guidelines themselves, there's a little bit of disagreement as to where ECG should go. Capnography, we've talked about that a little bit. Again, monitoring of exhaled CO2. Both California law and the ADA guidelines presently, and this may change, indicate that capnography is required for intubated general anesthesia only. The ASA monitoring standards indicate that capnography is required for all patients undergoing sedation or anesthesia. And I think the reasoning behind this is there's some discussion about different modalities where this is used, whether it's a closed airway or an open airway. But I think that there's general recognition that capnography is extremely useful because it gives you real-time, breath-by-breath monitoring of the status of the patient. Capnography and the AAPD guidelines, again, here there's a little bit of variation from the others. They indicate for moderate sedation, you can use an either-or approach. But the point here really is that they're always recommending 2 methods of monitoring of respiration. Here they're going to recommend 2 out of 3 with either capnography or auscultation of the breath sounds plus verbal communication with the patient. In other words, the patient's responsive. For deep sedation, AAPD indicates capnography should be used in most cases, however, recognizes that in some cases this may not be feasible, and if so, that should be documented and perhaps the monitor placed once the patient is adequately sedated. And again, this is real world stuff. There's no way you're going to put a capnograph on a struggling small child and get any useful information. Personnel. California, as I mentioned in a previous section, under state laws, that patients must be monitored on a one-on-one basis. There is not a specified number of staff. However, staffing must be adequate to effectively demonstrate management of office emergencies in order to pass the office evaluation. The AAPD guidelines and ADA guidelines, and as I mentioned, this 2-person for general anesthetic, 1 person for moderate sedation, that really originated with the ADA, and a lot of states have adopted that, and again, it's in these professional association guidelines. That's where they came from. The AAPD guidelines further stratify staffing according to level of sedation, and for deep sedation general anesthesia indicate that 1 person whose only responsibility is to constantly observe the patient's vital signs, airway patency, and adequacy of ventilation, and to either administer the drugs or direct their administration. I want you to take a look at that last statement because that's really what a lot of the discussion is about. Should there be this additional person who has duties that are distinct from those performing the procedure? California Society of Anesthesiologists submitted a statement indicating that they feel that sedation and anesthesia should be administered according to a single standard of care. And also they submitted a number of advisory statements and guideline statements, some of which were true guidelines and that they are evidence-based. The ASA advisory on granting privilege indicate that sedation practitioners who administer sedation should be different from the individual performing the procedure. Preoperative fasting instructions. Again, this is an area where California did not develop state laws because you need the ability to use some clinical judgment here. And I think some of the guidelines recognize that, so we don't have specific preoperative fasting instructions. We do have to do an evaluation prior to each administration of sedation or anesthesia. The ADA says dietary precautions should be considered based on the sedative technique prescribed, more or less leaving it up to the dentist. The AAPD guidelines take a little bit stronger approach in that they say the standards generally should follow those used for elective general anesthesia. They don't get more specific than that and indicate that further research is needed. ASA has now published evidence-based fasting guidelines. This is really a very good document. But the bottom line, and I think what most people tend to go by, is a patient coming in for sedation or anesthesia should be abstinent of liquids for at least 2 hours and solid food for a minimum of 6 hours. And again, this is only for healthy patients undergoing elective procedures. There's a lot of other situations, so maybe the people who drafted California law didn't want to make it too specific, because ultimately a practitioner is going to be judged according to the standard of care. Literature review. We conducted not an in-depth, but a brief review of the relevant medical and dental literature. As anyone who's delved into this literature knows, this can be quite a project. We looked at pediatric sedation studies, and these are usually case reports, studies of small groups. There are a few evidence-based studies, mostly coming out of the UK, that have looked at pediatric sedation. The quality of the studies is not generally high. We don't have a lot of systematic reviews. We don't have a lot of meta-analysis type information. We also looked at anesthesia-related mortality studies. There's some challenges associated with those, as we know. These look at anesthetic-related mortality over large populations, so you need a very large sample size, and I'll go into some more details, and I'll give you some examples of that. These were done in the US probably 10 or 15 years ago, and now they're being done most in other countries and in Europe. They're very resource intensive. Closed claims review have become more common. These are review of closed professional liability claims that are tabulated by liability carriers, professional malpractice. Probably the dominant study of this type are the American Society of Anesthesiologists closed claims studies. That was a project they did. It's a really interesting story. I'll digress into that a little because I think it's relevant. Back in the early 1990s, late 1980s, the anesthesiologists had very high malpractice insurance premiums, and they set about to do something about this, and their goal was to improve safety. And so they accumulated a large number of adverse events of different kinds using closed claims review, published those as papers, and a lot of, I think, what has been improvements in anesthesia safety came out of those studies. And as a result, interestingly enough, malpractice liability rates have gone down. State board outcomes data, there's a few papers about this, not many. I put them in mostly for purposes of comparison. So again, there's a lot of literature out there. Morbidity and mortality studies, I just picked a couple, and I'll explain why. First of all, most M&M type studies will give you both a numerator and a denominator. In other words, you have the number of adverse events that occurred, and the denominator is the number of cases, the total number of cases done. And so you have a ratio, and it's usually expressed as a ratio. Now, in order to do that, you have to have accurate reporting of the number of cases performed. So this study, that's a fairly recent study, came out of Germany, and I'm not saying you should compare the German system with the US system, but they do have a national data collection database. And so they were able to actually do this sort of outcomes research. And again, we're talking, this is one of the few studies that looked at ASA1, ASA2 in patients, relatively healthy patients, over 1 million population, or rather 1 million anesthetics given, and they found the mortality rate was, anesthesia-related mortality was 7 to 8 anesthetics per million anesthetics. Okay, and then there were studies done back in the late 80s, early 90s by a group in Harvard, and the way they did it was interesting too. They also have a numerator and a denominator because the Harvard hospital system has a reporting mechanism where all anesthetics given are tabulated, and so they basically calculated the number of adverse outcomes, divided it by the denominator, and came up with this number. And it's interesting because the author of this study commented that he was not really sure how valid the statistics were because you're dealing with very large populations and relatively rare events. But anyway, they're here because people throw these numbers around a lot, and it's important to understand what they mean and where they come from. It's also important to understand that for closed claims type studies, there is no denominator. You don't know how many cases were actually done. You have only, it's not a random sample of events. Not all closed claims, not all events result in a claim, and not all claims are actually associated with an event. So closed claim studies do have some limitations. Same way with state board outcomes. State board outcomes don't have a denominator. You don't know how many cases were done. We don't have a reporting mechanism for that. You only know that the events occurred, what they were, and roughly how many. And so those are some of the limitations. Again, some of the review of anesthetic-related mortality is challenged by the small numbers of adverse outcomes that occur. So you got to study really big populations. A lot of the papers, they'll come out saying, well, we didn't have any deaths in 25 or 30,000 cases. That's nowhere near enough. You got to have more like 1 million to see these numbers. And so those kind of studies, they're interesting, and they tell you complication rates. They're not really adequate to study mortality. There is no standard definition of an anesthetic-related death, and this has to be done by subjective interpretation of the evidence. So these are just some of the challenges that the authors of these papers pointed out. Pediatric sedation studies we reviewed. There were a number of these. As I indicate, the quality of evidence is not high. Adverse outcomes do, however, overall tend to indicate higher risk for younger age groups. A couple of the age groups that were reported in some of the papers are 1 to 3, 2 to 5. Bottom line, I think, is younger patients and patients with a higher ASA, that's the risk rating for the patient undergoing anesthesia, are higher risk. And that's reported in quite a large number of studies, so this data is out there. Maybe not the best data, but I think you can you can identify some trends. Board statistics. Okay, now this was done at the request of Senator Hill. The board tabulated all its incident reports. These are basically, we call them 1680Z reports. These are mandatory reporting of a death or hospitalization-related dental treatment. A dentist must report, and so in the case of this example, we have something that closed claims some of the other data collection systems don't have. We have mandatory reporting that hopefully would increase the reliability of this approach. If a dentist does not report a death or a hospitalization, there's an excellent chance that someone will find out and report it to the board, and then he will be subject to discipline for not reporting. So all of these 1680Z reports, reports of death or hospitalization, go through the Complaint and Compliance Unit and are entered into the Consumer Affairs CAS database. So basically, board staff went back, extracted the data, delineated the ones that were age 21 and younger, and they tabulated all incidents related to the use of all anesthetic modalities, local oral conscious sedation, parenteral conscious sedation, or what's known commonly as IV sedation, I guess you could call it moderate sedation, and general anesthesia. And the study period extended from January 1 of 2010 to December 31st of 2015. And again, as I mentioned, this was prepared entirely by on-board staff. The subcommittee did not have anything to do with this. In fact, I never saw this until my report was completed and it was assembled and posted on the web. Board statistics. What we found, and again, we have hospitalization statistics. I think there's 56 incident reports, and this is all in the last couple of sections of the working draft. And I'm not going to go over the hospitalizations because it would take a lot of time, and it's there for your review, and I think it's kind of self-explanatory, but I did want to talk a little bit about the deaths. So during that study period, we received notice of 9 pediatric deaths. 3 occurred in the hospital, all high-risk patients. 1 received an office general, 1 received oral moderate sedation, 1 received moderate sedation by another route. 3 involved local anesthesia only or local plus nitrous. That was something of a surprise, but if you look back at other reports, they really have similar kinds of results. There is mortality from local anesthesia in all these reports. And the distribution varies a little bit, but again, we see that, and I'll go into the next slide here because this describes it a little bit better. We see that the ages are usually around 2 to 5, in other words, the 3-year-old age group, and that really is the one dominant factor. So of the cases that involve the 9 pediatric deaths, only 4 of these involved general anesthetic. 3 were high-risk patients that succumbed in the hospital. 1 did receive an office administered general anesthetic. Now, the board staff, this is not in the report, and so I took some liberties here, and you know, this is not published data, but board staff asked me, do you have any idea how many anesthetics are given in California per year? And I said, well, you know, we don't really have a good data collection system, we don't have a database, but I'll see what I can come up with. So I went back to some of the research papers, and I looked at oral surgeons because they're big utilizers of anesthesia in the dental community. And they do have published papers that indicate, on average, how many anesthetics an oral surgeon does per year. And it's fairly consistent across different states and different reports. It's around 500 a year. So if you figure there's 725 GA permit holders who are OMS, you multiply that times the number of cases, you get 340 to 400,000 cases per year. Of course, this wouldn't include the dental anesthesiologists or other people. It doesn't include any of the sedation permit holders. And so, you know, again, I'm not telling you this is a hard number. It's really kind of a rough guess. And so if you calculate, if you extrapolate that approximately 40% were treated that were under the age of 21, you come up with a total of 136,000 to 160,000 cases per year for age 21 or under. And if you multiply that over the study period, you wind up with about 900,000, close to 1 million cases. You got to remember, California has almost 40 million people, 39 million people. So we're talking about a really large study population. A lot of anesthetics are going to be given. We got a lot of people out there doing it. And so, you know, a number of 1 million pediatric anesthetics over that period of time and that size population, I don't think is unexpected. But again, this is not a hard number. We also looked at Denti-Cal utilization because we were asked to look at utilization. We queried Denti-Cal about billing code incidents. You have a code for general anesthesia, deep sedation. Well, how many of those were done? Well, it turns out about 25,000 per year. And these are just the ones done on Denti-Cal, not anything else. So, and that doesn't include medical anesthesia claims done by anesthesiologists. So again, I think the point, you could put a lower bound on the number maybe using this, but it gives you an idea of the scale of cases that are done. So to wrap up, because I know you're all anxious to get your comments in and we'd like to get on with the meeting. California laws are consistent with laws in most other states with exceptions in the following areas that I've described: definitions, personnel requirements, differences in education for oral conscious sedation. California laws are consistent with some but not all professional guidelines. Exceptions, again, are similar to those in state laws: personnel requirements, monitoring, preoperative fasting. And to wrap up, adverse outcomes from pediatric sedation and anesthesia for dental procedures are actually quite rare, fortunately. We would like them to be rarer. No practice setting or provider model utilized in dentistry has been demonstrated to have better or worse outcomes. Nothing in our data stood out. Nothing in any of the studies stood out. There is no national outcomes database for tracking sedation and anesthesia. This would make it much better to do these studies. Anesthesia and sedation, however, are not without risk, even in healthy patients, and should be utilized appropriately. And the search for safety improvements must definitely continue. So that concludes my presentation. Thank you for your attention, and we'll have time for board member discussion.
Okay, thank you, Dr. Richer, for the subcommittee's robust and thorough investigation and report. And at this time, I would like to open up to board members' questions and comments regarding this report. Yes.
So, Bruce. So I have to admit, my son's been through at least 5 or 6 anesthesia situations with dental. Is amoxicillin still part of that pre-op or written instructions, or I'm just curious?
It can be. It depends on the indication.
Anybody else?
Come on, you got to have some questions.
Well, you answered all of our questions maybe before we even had them. So as I said,
Never that easy.
I'll bring up another one then.
Okay.
So my experience is sometimes the dental work is done in the hospital. Is that done with an anesthesiologist that's a dentist, or is that done with an anesthesiologist that is a medical anesthesiologist, or is it a little bit of some of both?
Well, it would have to be somebody who qualified for hospital privileges at that institution. It would probably be a medical anesthesiologist if it's an inpatient type facility. And it is frequently done there. And I think one reason is that there was a bill passed a number of years ago that actually mandated anesthesia and surgery center coverage by insurance companies for patients under the age of 7. And so a lot of cases are done in the hospital. In fact, some of the hospitals in our area, I believe they have some sort of legal requirement or something to take a certain number of cases, because I know they do. So it's not all done in an office or outpatient setting.
Okay. Anybody else? Okay. With that said, I will now open up for comments and questions from the public in attendance. Again, I want to remind you to confine your questions and comments to the report, to the content of the report. When you have a comment or question to ask, please take a seat at the table. Make sure that the microphone is turned on, and identify your name. If you represent an organization or association, please identify that association. And we invite and we look forward to your comments and your questions. So it's open for public comments and questions. If you just press the little button on the front, I think a red light will come on and let you know that you're in business.
Is that working? Okay, well, my name is Leonard Tycho. I'm a dentist, a physician, and president of the Oral and Facial Surgeons of California. Our organization appreciates the opportunity to work with you all on the Anesthesia project and all of the effort that's gone into the working document. To complement the board's anesthesia morbidity and mortality data, our organization felt it important to estimate the number of anesthetics delivered by oral and maxillofacial surgeons, to obtain a denominator for the outcomes data, and to give context to the number of poor anesthetic outcomes. The off-stock written response includes a literature review and closed case claims data from OMSNIC, which is the largest malpractice insurer for oral and maxillofacial surgeons in the nation. In addition, OFSOC conducted a survey of its membership. In July of this year, we sent out a survey to the 725 active members of OFSOC. We asked members to search their practice database and report the number of pediatric and adult anesthetics from 2011 to 2016. Of the 725 members, thus far, 284 have replied to the survey. So to date, we have a response rate of 39%, which we feel is pretty good for a survey. The specific data is summarized in our written report. From this data, we estimate that in the 5 years between 2011 and 2015, California oral and maxillofacial surgeons did over 1 million pediatric deep sedations and general anesthetics. On review of the dental board's working document, we find a single pediatric anesthetic death in an oral maxillofacial office. So to say that again, and with all literal meaning, we estimate that the risk of a pediatric anesthetic death in an oral maxillofacial office is less than 1 in a million. Though OFSOC believes that even one death is unacceptable, we are certain that our anesthetic model, though different than that of medicine, compares to our medical colleagues and to the nurses who have testified before you all. Every year in California, our members provide an estimated 450,000 anesthetics to both adult and pediatric patients. We feel that we have an excellent safety record, and though we appreciate input from medicine and from nursing, we feel that wholesale changes to our OMST model of anesthesia is not supported by any data and is therefore unwarranted. Instead, we ask the board to consider some recommendations to further refine our model and our safety record. Next to me is Dr. Marinon, who's our anesthesia chair, and would like to go over that.
Thank you, Dr. Tycho, and thank you to the board for taking the time to listen to my comments. Oral and maxillofacial surgeons are recognized as the leaders in dental anesthesia safety. As a matter of fact, many of the dental anesthesia safeguards in California and in place around the country are there because of the efforts of oral surgeons in California. Oral surgeons recognize our responsibility, or the responsibility we have for our privilege to provide safe anesthesia to patients. In 2012, the American Association of Oral Maxillofacial Surgeons established parameters of care for anesthesia in outpatient facilities and a periodic anesthesia evaluation program, office evaluation program. These parameters of care are far more rigorous than those in California. The parameters set standards for outpatient management of patients under anesthesia with respect to proper documentation, facilities, required equipment, They require pre-anesthetic physical examination and laboratory assessment as indicated. Standards are set for the management of perioperative complications and emergencies. In addition, the guidelines are established for risk factors that might exclude a patient from outpatient-based anesthesia. As noted by Dr. Witcher, adverse events are rare. Dr. Tycho also noted that outpatient anesthesia by oral surgeons has an exemplary safety record. Oral surgeons have long recognized that a team approach to anesthesia is necessary to maximize safety. Well-trained auxiliaries have been the hallmark of our practice of anesthesia. To that end, and many years ago, the Oral Facial Surgeons of California established the Oral and Maxillofacial Surgery Assistant Training Program. That allows auxiliaries to obtain certification to assist in outpatient oral surgery procedures performed under anesthesia. The course teaches anatomy, physiology, pharmacology, and the recognition and team management of anesthesia-related emergencies. Anyone who practices anesthesia knows that respiratory compromises are inherent in general anesthesia. Closed claim data from both the medical anesthesia and oral surgery literature has found that failure to recognize respiratory depression and obstruction is the most significant cause of mortality and morbidity. In January 2013, the Oral Facial Surgeons of California adopted a position paper on the use of capnography. In addition to direct observation of the patient, continuous monitoring of heart rate, blood pressure, oxygen saturation, and auscultation of breath sounds, the position paper requires members to use capnography for moderate sedation, deep sedation, and general anesthesia. This policy is consistent with the policies of the American Association of Oral Maxillofacial Surgeons and the American Society of Anesthesiologists. Unfortunately, the policies and standards that I have just outlined are only required for oral and maxillofacial surgeons who are members of AMIS and the Oral Facial Surgeons of California. The California dental anesthesia regulations do not require capnography or the rigorous standards set forth by AMIS or the ASA for patients undergoing moderate sedation, deep sedation, and general anesthesia. Therefore, the Oral Facial Surgeons of California would like to recommend the three following changes to the dental anesthesia regulations. Number one, adoption of the AMIS parameters of care to all dentists who practice sedation and general anesthesia. Number two, require the presence of 2 trained and certified auxiliaries during outpatient moderate sedation and general anesthesia. Lastly, the requirement for capnography monitoring during moderate sedation and deep sedation, consistent with the policies of the ASA and AMIS. And I welcome any questions.
Thank you.
Sorry, would you repeat number 3?
Number 3 is the requirement for capnography monitoring during moderate sedation, deep sedation, general anesthesia, consistent with the policies of the ASA and the AAOMS. And yet, as Dr. Tycho said, these recommendations are in our written report to the board.
Good, thank you very much. Appreciate your comments.
The board will be receiving all these comments, so thank you for taking notes, but it'll also be distributed.
Okay. Does any member of the board have questions for this individual? Yes.
So the denominator, the statistics you gave, so was it 1 million total in the 5 years, and was that just children?
Yes, again, that's in the written report, and that's over 1 million, just pediatrics. And our definition of pediatrics, which was put on by the legislature, is 21 and younger.
Okay, so that'd be about 200,000 a year.
Well, our statistics are slightly different than Dr. Witcher's. So far in our survey, of the total number of general anesthetics and deep sedations, about 48% of them are on pediatric patients, 52% on adults. So roughly half of the 450,000 per year would be pediatric.
Okay, because that's like, I think 2 to 4% of the children in California. I mean, it seems like a very high statistic. Maybe I'm doing the math wrong.
Any other questions or comments?
I have a question.
Yes.
So AMIS has training
classes for auxiliary and AMIS members. Would those classes be available to general dentists or pediatric dentists, if so required, if they're not AMIS members?
Actually, I have taught in the AMSA course, and I taught the medical emergencies portion of that. And we frequently have auxiliaries from general dental offices who attend that course.
So California.
That's right. That's the AMSA program within California. AMIS also has a similar program. It's the dance program that's available throughout the country.
Thank you. Any other questions or comments from board?
I have a question. Do you have any recommendations that would really help us address the pediatric age group?
Well, I think what would mesh nicely with current California law is that children 7 and under are, insurance is required to pay for an anesthetic at a hospital. So I think that if there had to be any delineation on, say, how old a child would be, our organization would be okay with a younger age, like say 6 or 7. It seems like that's the more critical age. And also there'd be insurance coverage, although nowadays with high deductible plans, it still might be quite expensive.
Thank you. Any other? Okay, thank you, gentlemen, very much for your appearance with us today. We appreciate it. Good morning, welcome.
Now?
There you
Thank
are.
you. I'm Paul Rigiardo. I'm a pediatric dentist, and I am here representing and speaking on behalf of both the California Society of Pediatric Dentistry and the American Academy of Pediatric Dentistry, who both commend the board and the Pediatric Anesthesia Subcommittee on the depth, the breadth, and the attention to detail contained in the anesthesia working document of July of 2016. It's evident to us the board is addressing seriously its mandate of public protection and is researching responsibly what measures in law or regulation can make pediatric dental anesthesia even safer in the future than it is today. We would respectfully submit a correction to the reference on page 26 of the working document regarding the process by which the joint American Academy of Pediatrics and American Academy of Pediatric Dentistry guideline for monitoring management of pediatric patients during and after sedation for dental therapeutic procedures is developed and approved by the governing bodies of both organizations. The document states it's unclear whether input is solicited from non-member dentists, outside organizations, or the public, and detailed information is available to AAPD members only. And AAPD guidelines are forwarded to the American Academy of Pediatrics for endorsements and are then published as a joint document. That information is incorrect. The guidelines are developed jointly by both organizations, not merely forwarded to the AAP by the AAPD for endorsement. Physician anesthesiologists and other pediatric medical specialists are involved in the development of the document, as are AAPD specialists in dentist-administered anesthesia. Non-member dentists and representatives from outside organizations and members of the public may attend AAPD reference committee hearings where a draft document is being considered before adoption and may ask to speak or provide testimony on any details of the proposed guideline before it is modified or adopted. AAPD and CSPD look forward to the completion of the comprehensive and impartial analysis by the Dental Board of pediatric sedation and the laws, regulations, and policies which govern its administration. We support and applaud the open and transparent process by which the subcommittee is moving forward to identify any necessary statutory or other changes to the administration of office-based sedation which improve the margin of safety for pediatric patients. We believe this information is essential in determining the course of action necessary to ensure the highest level of care for the patients we treat.
Okay, thank you very much. Any questions or comments from board members regarding this presenter? Yes.
Do you have a written copy of that so I can enter that correction?
I believe Linda's
Thank you.
already distributed.
Thank you. And thank you for that clarification. I wasn't quite sure. So it's good to hear.
Thank you, Bruce.
Okay. Any other comments or questions? Okay, thank you very much. Appreciate your attendance.
Good morning, Brianna
Good morning.
Pittman with the California Dental Association. Dr. Felsenfeld, who many of you know is our liaison to the dental board, couldn't make it, so I'm here in his place. So CDA appreciates the significant work that's gone into producing this report. We know that it was a heavy lift to complete in the timeline provided, and we believe that it forms an important foundation for moving forward and formulating your recommendations. We'd also like to thank you for the proactive outreach to stakeholders, not just within dentistry, but to all those who are concerned with pediatric dental anesthesia safety. There are a few important things we learned from this report in regards to the most tragic of events, a patient's death. Pediatric anesthesia deaths, as was highlighted by Dr. Witcher, in recent years were rare, and they've occurred in a variety of settings under the care of different anesthesia providers. There is no single pattern, which is relevant information as recommendations to improve safety are considered and formulated. The report also shows that children at high risk are being properly treated in hospital settings, reaffirming that training and treatment planning is working well and is putting the needs of patients first. Rare is still tragic, and we need to do everything that we can to reduce the risks of anesthesia. So to that end, CDA looks forward to working with all the interested parties to implement the board's recommendations for improvements in pediatric anesthesia, and we look forward to those. Further, we agree with others who recognize that additional data and better methods for collecting that data is crucial to future monitoring and evaluation efforts, if those efforts are to be accurate and useful. We believe that comparable data should be collected across healthcare disciplines to provide a fuller picture of pediatric anesthesia and sedation in all healthcare settings. If we are to truly understand this issue and have an accurate perspective on it, we must know the actual denominators and numerators, as Dr. Witcher mentioned, data we simply do not have now. Finally, this report confirms for us that anesthesia always carries a risk, no matter the setting, the situation, the provider type, including having a separate anesthesiologist present. We simply cannot create a never situation as much as we would like to that eliminates all risk. No model of care in dentistry or medicine can ensure that nothing tragic will ever happen. We must do everything we can to reduce the potential for risk when anesthesia is required, but we also should do everything that we can to reduce the number of children whose dental disease is so severe that it requires anesthesia. CDA commits, and we look forward to working with you, the board, and others here today to collectively do everything we can moving forward to be more effective preventing disease and to making safety improvements where we can. Thank you.
Thank you very much for your comments and your contribution. Any questions or comments from members of the board?
I have a question. Thank you for your comment about thank you for your comment about prevention. We had a really great talk by Dr. Kumar about what he's trying to do in the state of California. The best way to prevent anesthetic risk is to reduce the need for treatment. We're never going to treat our way out of this situation. I mean, early childhood caries is of epidemic proportions. It would really make a lot of sense if we could focus on prevention and prevent anesthetic problems that way.
Absolutely, and CDA will continue to work with everyone. I mean, we have a long history working with Dr. Kumar, the board. I think we need to work on both the numerator and the denominator to increase safety. Thank you.
Okay. Thank you very much.
Get it on here. Larry Trapp. here representing the California Society of Dentist Anesthesiologists, and I appreciate the full board's attention to this. It's wonderful that you can and want to pay attention to it. Every death in a child, or an adult for that matter, is a tragedy. They're unavoidable, as the last speaker pointed out, because there is inherent risk in anesthesia. We will never drop it entirely off the site of our perspective, but we must do the maximum and the best we can do and minimize it to the lowest possible number. I'm going to make several specific comments. One regarding the report, I wanted to clarify, I'm not sure the committee got all the critique that they needed and wanted, because the report, if you notice, is very poorly organized. That is, the pagination. Page number 1 occurs in 2 different locations. The appendices, one of them is not got any pagination at all. And so I want to emphasize that. I want this document for everybody to critique it the best possible way, and I think those changes will make it better in terms of getting feedback. I also want to just make the comment that the incident report that we currently do is, to me, clearly become obvious that it's inadequate. And this is the report that the dentist makes to the board when a poor outcome occurs. And the current requirements are, if it's a unexpected hospitalization over the 24 hours, or it's a mortality, they need to report within 7 days. And all they have to do is write a letter saying basically that it happened. And I think we're of the opinion that a whole lot more information is needed. Number 1, to try and generate data. Number 2, to allow the investigators of the board to be more fluid in their response. And so I think it's a long-term effect, a long-term job, big task. And we wanted to offer to partner with the board from Loma Linda University's Department of Dental Anesthesiology, if you would so wish, to develop the long-term incident report. We have people who are experienced in data acquisition, and I think it would be helpful to develop a form that would appear online and available to any practitioner who has such an outcome. It's a very, I'm sure, a very difficult time for them to know where to turn. Moving on, I wanted to, I mentioned at the report at the committee hearing that there is an article which is very enlightening that was published in the Dallas Daily News in December of 2015 on poor outcomes in dentistry. And one of its major conclusions was that boards around the country don't handle reporting very well. Data gets expunged from the records after a process is undertaken, which to me makes no sense at all. And I want to encourage that no data that's generated regarding either expert opinions, which I do as well for the board, or investigations is expunged. And I think it's to the board's benefit to not expunge those records, because if somebody brings the subject up again later, then what does the board do? How does it respond when all the data's gone? So,
Dr. Trapp, I have to remind you now that we need you to close. You're
Okay.
over your 3-minute mark.
Thank you. Well, of course, I have 6 or 7 times enough time. I can only go through the few things, but I encourage the board to not expunge any data, develop data generating capabilities. That's what the Dallas report was really found, is that there wasn't good opportunity to generate data.
Thank you very much.
Thank you very much.
Do we have any questions or comments from board members? Yes, Bruce.
I'd just like to acknowledge Dr. Trapp and thank him. He was one of my instructors. And please go ahead and submit your comments in writing, or we can talk later.
That's an age-related experience. Thank you.
I just wanted to note at this point, this has been a working document. We thought it was necessary to get it out for people to go ahead and review it. Obviously, when it reaches its formal format, it will look beautiful. The pagination will be proper. The font will be easy to read. The appendices will be notified. So thank you, Dr. Trapp, again for that comment. We've heard your message.
Okay, do we have any other stakeholders' comments?
Hello, my
morning.
name is Dr. Diana Belli. I am a residency-trained dental anesthesiologist, and one of the comments that I would like to make is a good portion of the public, I think, doesn't actually know that we exist, and we are pretty much dentistry's parallel to the medical anesthesia specialty. I trained for 2 years doing nothing but anesthesia, and the model under which I practice is that I currently go from office to office. I provide general anesthesia. That's all I provide, is I do the medications, I take the patient's medical history, I do the monitoring, while another practitioner does the dentistry. I originally, when I got out of my residency, I actually did 2 years in the children's surgery centers, where I treated over 3,000 kids, 13 months to 13 years. But I think one of the things I want to make a point of is that the general public, and for the most part, and I hear this all the time, doesn't really know that we are there to provide this service. Second thing I wanted to make a point of was that before I did this is a second career for me. I was originally in high tech for 20 years, and one of my areas of expertise was data analytics. So, and after evaluating the data that was in this report, I realized that, number one, there were only about 11 attributes that were recorded for the data. There wasn't a large data set, which actually usually makes the analytics much more accurate. And I also identified about 28 other items that I thought should have been tracked or should be tracked for these incidences. Because I think the question is not, is anesthesia or sedation safe for pediatric dentistry? And the question is, under what circumstances are these incidences occurring? And without capturing the right data and without actually making it quantifiable, I think that we're not going to get an accurate assessment of that. Thank you.
Thank you very much. Any questions or comments from members of the board?
One.
Yes.
Sorry, I have a question for you. You said there were about, how many different categories you thought should be collected?
I added about 28 more attributes of these incidences. So for instance, you know, one of the questions would be who was present in the room at the time the incident occurred? Who was present in the practice? What was the highest level of life support training of the personnel available? You know, was there, does the office have a documented emergency protocol in place?
So my question is, so I'm sure you're willing to share with us all those recommended.
Yes.
Yeah.
Absolutely.
Okay, so if we could get it in writing. I
Okay,
think,
sure.
Yeah, appreciate you.
Thank you very much.
Go ahead.
In listening to all the talk about collection of data, a lot of times if a doctor or dentist gets into trouble, the first person they call is their insurance company. And usually they tell or instruct the dentist or doctor not to say anything. And so I think the disconnect is where doctors or dentists won't really want to come clean with it, but they're instructed because of liability not to say or not to put out the whole story, which is sometimes our difficulty in receiving certain data as a board. So I just want to put that out there.
Yeah, if I could address that. Whenever a professional liability company gets a notification, they open a claim for that incident. And that can be utilized for closed claims analysis, but obviously it takes a long time for those to work through, so that information isn't available for a while. That does not negate the responsibility of the dentist to report to the board. That is mandatory. And just for those of you who know, we've got the message loud and clear that we need to expand the reporting parameters. Some possible ones were listed in Assemblymember Thurman's bill, and having to do the data collection and data analysis, board staff tells me they're very much aware of the shortcomings. So thank you.
Thank you. Any other stakeholder comments?
Good morning. My name is Jeff Pogue. I am a physician anesthesiologist who specializes in pediatric anesthesiology. And in my 30-year career, first as a pediatrician and then as a physician anesthesiologist, I've worked with many dentists and oral surgeons, so I have a great deal of respect for what you all do. I want to thank the board for having us today to provide commentary. I'm with my colleague, Dr. Mark Zakowski, the current president of the California Society of Anesthesiologists, and we represent the CSA today. You should have received a written statement with our comments, but I will try and summarize the highlights here. My specialty, anesthesiology, is the only medical profession recognized by the Institute of Medicine in 1999 for implementing patient safety measures and protocols that resulted in a 50-fold decrease in anesthesia-related deaths due to largely physician anesthesiologist efforts. And I think Dr. Witcher alluded to some of that in the outcome data in his talk, and that was a very good talk, Dr. Witcher. Presentation. As physician anesthesiologists, we're here to offer assistance as the content and national experts in anesthesia safety, patient safety, medications, clinical monitoring, and airway management during sedation and anesthesia. And this requires a systems approach. So our recommendations basically entail three areas. First of all, terminology. There needs to be updated terminology, as others before us have commented on. As a first step, we recommend revision of the Business and Professions Code and all applicable regulations to reflect the current classification of states of sedation and anesthesia. These have already been talked about today and are in the updated AAP, American Academy of Pediatrics, and AAPD, American Academy of Pediatric Dentistry, updated guidelines from the July issue of the Journal of Pediatrics. And that is recognition of the four categories: minimum sedation, moderate sedation, deep sedation, and general anesthesia. And a recognition that the Centers for Medicare and Medicaid Services do not see a distinction between deep sedation and general anesthesia. Sedation and anesthesia is a continuum, and that is a point that we wish to make. The second comment has to do with the route of administration. The distinction between oral and parenteral techniques, so oral versus IV, rectal, nasal, intravenous, should be abandoned, in our opinion. Some of the patients in the cases that were reviewed by the subcommittee who suffered adverse outcomes, including death, were a result of oral medications alone. This practice is called oral stacking of medications, and therefore we recommend categorization by depth of sedation, not by route of administration. We see this as a key area for where the laws can be updated in the Business and Professions Code and applicable regulations.
Dr. Hogue, I just have to remind you that you've gone over your 3 minutes, so are
Okay,
you
sure.
nearly concluding?
And finally, the third recommendation has to do with the definition of new permit categories to replace those currently in existence, eliminating the term conscious sedation, and to stratify permits by depth of sedation. So One recommendation would be minimal sedation for children, adhering to the AAPD guidelines. And the second would be a category for moderate and deep sedation and general anesthesia for children. This would require adherence, again, to the guidelines already alluded to, including the presence of a sole provider with anesthesia expertise whose responsibility is to constantly observe the patient's vital signs, airway patency, inadequacy of ventilation, and administer drugs, and so forth. This would include end-tidal CO2 monitoring, known as capnography, which Dr. Witcher talked about and others before us. And we feel this should be required for moderate, deep, and general anesthesia, actually all sedation services.
Thank you very much, sir, for your comments.
All right.
I appreciate it. Any questions or comments from board members?
We're in receipt of your document, and we'll make sure all the board members see that. Thank you.
All right.
Dr. Mark Sikowski, President, California Society of Anesthesiologists. I want to thank Dr. Wichiter and the board for the excellent job they've been doing. It's a big topic. Yeah, it's a big topic. Just to reiterate a couple points, it is California Society of Anesthesiologists policy to advocate for one standard of care across the continuum. The public also, I imagine, would want to have one standard, whether they're coming for surgery or dental procedures, whether it's in the hospital office setting or dentist office. Also, adoption of some of the more medical aspect approach to these problems. It's known in the medical world that for every death, there's an estimated tenfold, that's 10 times amount of what's called near misses. That may or may not include morbidities, and that when you collect data, I strongly urge you to try to incorporate that data also. That is very useful in terms of looking forward and finding system errors for correction. And also to consider, as you mentioned in your report, some of the facility standards, which include, of course, personnel, equipment, and medication. In my letter to the board of June 30th of this year, I mentioned succinylcholine is the definitive treatment for life-threatening laryngospasm. You may want to consider options like that also. And thank you very much for all your hard work.
Thank you. Any questions or comments? Yes, Bruce.
Yeah, if I might make a point of clarification, the emergency drugs do include a muscle relaxant, which implies succinylcholine.
Any other questions or comments? Thank you very much, gentlemen. We appreciate your contribution.
Hello.
Good morning.
Good morning, members of the dental board. My name is Dr. Anna Kaplan. My nephew Caleb was one of the children that had passed away.
Good morning.
Oh, good morning.
Please do not discuss any specific case.
Okay, I won't
understand
discuss
that-
anything. I just wanted to
Thank you
introduce
so
myself.
much, because the board would have to recuse themselves.
Got
to
it.
pending case. Thanks so much.
Anesthesia is one of the only ways a child can enter a dental office and leave in an ambulance. As a public safety board, I urge you that this should be your #1 priority. And 15 years ago, a blue ribbon panel was put together that wanted to have that identified this issue and recommended a standing committee to look into each of these cases to look for systems errors. That, to my knowledge, does not exist and hasn't existed, and that was a long time ago. I am just urging you that there's no more time to waste. While we've been having this discussion, in this past year, another child has passed away in a dental office due to anesthesia. I'm urging you to listen to the anesthesia experts that are here today in the medical field and the dental field. Look at those AAPD, AAP guidelines that state that there should be a separate anesthesia provider in the room monitoring the patient at all times. I believe that there should be, if there were a second anesthesia provider, that my family would not have suffered as we have.
Excuse me once again.
I'm sorry, I'm trying not to.
Please, thank you.
You have the opportunity today to listen to these these advisors to make this working document show some new regulations that don't do little but do a lot to prevent the next child from passing away in a dental office. And I'm urging you to take into consideration everything that is said. Thank you.
Thank you very much. We appreciate your being here. Good morning.
Good morning. My name is Paula Whiteman. I represent the governing board of the California American Academy of Pediatrics. Thank you so much for letting me come and speak today. We too have a letter that we submitted in advance with our comments. I would like to remind the board that we have no financial interest in the outcomes of these proceedings. As pediatricians, we just represent our interest in taking care of the whole child and the whole child's well-being. We want to urge that all dentists and oral surgeons in California comply with the AAPD guidelines on pediatric anesthesia in dental settings. We'd like to recommend that your subcommittee integrate the recommendations of the California Society of Anesthesia letter that they just provided you, dated August 17th. We appreciate Dr. Witchard's comment that he would like these events to be rarer. And with that, the California American Academy of Pediatrics requests an immediate and full moratorium on the single operator anesthesiologist model when a child is placed under moderate to deep sedation in a dental office. I'm just going to say that one more time. We would like to request an immediate and full moratorium so that no child should have a potentially preventable and unnecessary death during the time it takes for the California Dental Board to deliberate on all the comments and come up with their final statement that you said would come out in January of next year. Thank you.
Thank you very much for being here and your contribution.
Good morning. Thanks
morning.
for the board of having this hearing here. My name is Richard Stafford. I'm a dental anesthesiologist. I've been past president of the California Society of Dental Anesthesiologists, and I've also in the past been on staff at both USC and Loma Linda. At this hearing and at the past hearings, there have been approximately 5 groups commenting. For the 5 groups, the American Academy of Pediatrics, the American Academy, the CSA, physician anesthesiologists, the nurse anesthetists, and the dental anesthesiologists have supported some type of regulation that would enhance safety in children under the ages of 7 years of age, meaning a separation of the individual providing the general anesthesia and the individual providing the dental procedures for general anesthesia under the age of 7. I think 4 of the 5 groups are very concerned about this, and they're in agreement that that population requires special protection. The one group that doesn't support that, I'm sure we can bring them along, the oral surgery group, I'm sure we can bring them along to support some type of recommendation from the board to protect that particular population. When we get involved, a lot of groups have a lot of good recommendations. The problems that one can foresee is when one decides to have a committee or a group of people together trying to formulate recommendations, it could take years before any type of resolution or solution or agreement is reached. So, our recommendation is to, at this point in time, have the board strongly recommend that the person providing the anesthesia and the procedure for general anesthesia under the age of 7 be separated. And also, at a point in time, appoint committees, whatever needs to be done, to address the issues that the other groups has. So an immediate separation or support of legislation that would occur in the beginning of the year, I think would be beneficial to enhance the safety of children. A couple thoughts. I know we're limited on time. At the last meeting, there was a discussion between a CDA and a dentist anesthesiologist, Mike Mashney, about the risk of anesthesia in the dental office. Dr. Mashney said that if he was doing both the procedure and the general anesthesia, his liability coverage would be higher. A representative from CDA did say that that was not quite accurate. We do have a letter from TDIC, CDA's liability coverage, saying that yes, if you have a individual doing both the general anesthesia and the procedure, your liability premiums are considerably higher.
Thank you very much.
Any questions?
Any questions?
It seems to me that, I get your point, but there is a thing known as surgical risk and liability from oral and maxillofacial surgery type procedures, including nerve damage, malocclusion, chronic pain, things like that. Those procedures carry a significant liability. Wouldn't you think maybe that was the reason for the increased liability
Well,
if that's added on to the anesthesia?
That's a good point, Dr. Witcher. I would answer that by saying in the past, and you've been involved in these board meetings before, and we've talked before, the general anesthesia permit process, the IV conscious sedation permit process, all the laws and regulations governing sedation and anesthesia in the office, the board has relied upon the experts in the field to bring that knowledge to the board. And the board has, in the past, has always used the experts in the field of that particular study to bring that information to them. And four of the 5 groups here that are experts in pediatrics and anesthesia have suggested that something be recommended. To address your question, yes. You know, I'm not an expert in nerve damage, oral maxillofacial surgery, and I'm sure that has something to do with it. But if you look at TDIC's statement, it's for a general dentist performing general anesthesia. I don't think, with due respect, general dentists shouldn't be doing any type of craniofacial surgery, any nerve augmentations, any alveolar augmentations, any sinus lifts. So if your question is it the anesthesia in addition to the procedure, or is it the unique procedures associated with oral and maxillofacial surgery? It could be that the procedures in oral maxillofacial surgery are more complex than just general dentistry. And then when you add on that the general anesthesia, it increases the risk to the patient. And you might be talking about adults, but we're specifically talking about children. My practice for the last 25 years has been pediatric dental anesthesia. The group that I see are primarily 7 years and under. And I think if that answers your question, or if I've confused the issue, you can please ask another.
I appreciate your discussion, but the discussion of liability claims and liability insurance coverage premiums is hardly germane to our discussion here today, so I appreciate it.
Well, it was brought up last time. I just wanted to correct that.
Okay, but I understand, but it's a lengthy discussion in that area is hardly germane.
Yeah.
Thank you.
I agree.
Any questions or comments? Thank you
Thank
very
you.
much, appreciate it. Yeah, if
Gail Matthew, California Dental Association. I was the CDA person in that Thursday.
I understand, but we need to limit our discussion on this subject area of liability.
All I did want to say is that we have submitted to the board for the record the item that is being discussed right now for clarity.
I appreciate it, thank you.
There we go. Good morning, Board. My name is Dr. Jimmy Tom. I'm a dentist anesthesiologist. I'm the president-elect of the American Society of Dentist Anesthesiologists. I'm a associate clinical professor of dentistry at the University of Southern California. I'm the newly appointed ADA representative for the ASA task force on moderate sedation provided by non-anesthesiologists. And I'm on vacation, but I'm here to I think this is important enough to testify in regards to the board's decisions and actions so far, and I applaud the board and the committee for their efforts so far in regards to improving the safety in regards to anesthesia and sedation, especially for our pediatric patients. And I know it's a lot of work, just knowing that compiling all this data over a long period of time is a monumental task. One of the things that I wanted to revisit was the American Society of Dentist Anesthesiologists letter to the board about a month ago in regards to the changes that should be made. And one of the first recommendations by our organization was to revisit and reconsider the establishment of a multidisciplinary committee, or at least a group, to analyze, revisit, update, and even to change, if necessary, the anesthesia regulations in regards to California dental anesthesia provisions. That was recommended by a 2005 Blue Ribbon panel chaired by a colleague of mine, now deceased, John Yagela out of UCLA. And he recommended that this panel be comprised of an oral surgeon, dentist anesthesiologist, pediatric dentists, periodontists, and all others who are involved and have some stake in the provision of dental anesthesia to our patients here in California. So, like Dr. Witcher had mentioned in regards to the guidelines that are continuously updated by other organizations, other professional organizations such as the ASA and the AAP and the APD, those are revised every 5 years or so. It would be nice to see if California could really lead the way in terms of revisiting, relooking at all these provisions that we have in our state on a continual basis by a formal means. Thank you for your time, and thank you for your efforts so far.
Thank you very much for spending part of your vacation with us.
Absolutely.
Appreciate it. Any comments or questions from the board? Okay, thank you very much. We are still open? Okay. With that said, the board is going to take a brief recess, approximately 10 minutes, and then we will reconvene. So thank you very much.
I just wanted to comment before Dr. Morrow continued the meeting that it looks like most of the people relating to the anesthesia project have gone, but just for the record for the board and for the webcast, this is only the beginning of this discussion, obviously. This is the first time the board has had the opportunity to talk about this, and we are moving forward. The subcommittee is continuing to take comments from people, interested parties, stakeholders, and we'll incorporate that into the next document, which may be another draft, it may be the final, but we're going to continue to work with groups out there before actually providing a final document. It is likely that another board meeting prior to the December meeting will be required, and that's why it's important that you look at your October dates that I'd given you for the strategic plan, because we would incorporate it into that time, okay? So we're talking about perhaps an abbreviated board meeting to discuss proposed recommendations and to take public input on that. That would be at in the October timeline. So we'll be contacting you to see your availability, and we'll see where that we'll be able to coordinate that with our strategic planning session. Thank you.
Thank you. Moving on to agenda item number 19, legislation.
Excuse me? Do we comment on the last report, or we don't do any of that right now?
On,
The board? We heard the public, but does the board?
sure, would you, can we open? Sure. We can
Well, I
open
know we
up
asked
for board.
questions at the beginning. I didn't know we were commenting then.
Okay, we can open up for board comments or questions. Sure.
Okay, I would like to add, my experience is that the number of children going through anesthesia, whether we have the data on the denominator or not, my impression is that the numbers are going up. And so any way we can get an idea of what those numbers are. And when I talked to the second dentist that spoke, if it's 450,000 a year, that's 4.5% of children, or 4.5% of children in this state may be having anesthesia treatments, but that includes potentially wisdom teeth and extra teeth. So maybe it is looking at a younger age and trying to get a real idea of what that number is.
Right.
But I don't know if there's any way to do that.
Did you hear the question, Bruce?
I did, and, you know, I was trying to develop some of that information. I have a section on that that's not fully developed, but I can work on the information that I have and maybe flesh it out a little and get it to you.
And I might be able to go back and ask Santa Clara County if there's any way we've been collecting that data and try and get you what we're doing in Santa Clara County. It could help.
You know, you might be aware that several years, I guess it was 2 or 3 years ago, there was a lot of activity in Sacramento about access to anesthesia for kids because Sutter Health stopped taking the insurance. And I know CDA had a lot of discussions, and they're very interested and been working actively on that sort of issue. And so they've done a lot of work in this area.
Any other comments or questions from the board regarding our previous agenda item? Okay.
And can I just say thank you for all the work for the two of you? I mean, it was an amazing amount of work, and I'm glad I didn't volunteer.
Yes. Yeah, and I also want to voice my appreciation for the job that the subcommittee has done. And believe it or not, they both have full-time jobs besides. And I hope you still have those full-time jobs. We do. Okay, great. Thank you very much.
And staff too, because
Yes,
you
a
could
lot
tell
of
underneath
staff
there was a lot of.
involvement. It's been a real project, and we had to set things aside in order to make it happen, but it was important, and that I'm glad that we were able to do it. Okay, agenda item 19, Lucy. Are you going to start with this one? Great, thank you.
Okay.
So for agenda item 19A, we have is the tentative legislative calendar, which is information only. And so kind of dates to be aware of, August 19 is the last day to amend any of the bills on the floor. And August 31st is the last day for each house to pass bills. And then just kind of a note, on September 30th, it will be the last day for the governor to sign or veto bills passed by the legislature before September 1st and in the governor's possession on or after September 1st. And so that's kind of like the important dates to keep in mind for legislation. And then next we have is the discussion on legislation for 19B.
Lucy, before we go on, I just wanted to say, members, that we often get to this time of year and there is an artificiality about our timeline and the timeline of the legislature. So I want you to keep in mind that there are barely 2 weeks left. If there are things that we look at and want to suggest significant things, changes, the legislature is in the process where things are on the floor now. And so it's our hour has passed. So I ask you to keep that in mind as we look at the bills that are left.
Okay. And so looking at agenda item 19B, discussion and possible action item, actions on legislation, we divided that section into two, informational only as well as discussion items. And to start off with the informational only legislation, we have AB 1707 by Assemblymember Linder. That failed to pass the first house, so it's no longer active or on the floor. Next is AB 2048 by Assemblymember Gray, which was regarding the National Health Services Corp. State Loan Repayment Program. That does not apply to our board, and so we kind of stopped following along with that bill. Next, during our May meeting, a few bills were mentioned, and so one of them was AB 2207, Assemblymember Wood's bill regarding the Medi-Cal dental program. And so this bill pertained to the performance measure for the dental fee-for-service and dental programs under the California Medical Program 2020 demonstration project. Since the board's function is to regulate and discipline, this isn't a bill that we would take a position on because, again, it is regarding the performance measures. And there's a link for those who are viewing it electronically that you can access. And for those who don't have that ability, it's on LegInfo, which is also included in the packet, that if you wanted to read the language for your own self, you can do that also. Next is AB 2744. Again, that was one of the bills that were brought to our attention.
It appears that the bills you were talking about right now aren't on the agenda.
I'm just giving an information only on those as.
You can't do that,
we're-
unfortunately. You can only comment on or mention the bills that are on the agenda.
Okay. So then for our discussion items, or the bills that are on the agenda, we have AB 2235, which is Assemblymember Thurman's bill. Recently, it kind of passed Senate, and so it went through a lot of amendments, and so currently, in amended form, this bill essentially requires the Dental Board of California by January 1, 2017, to report to the legislature on whether current statutes and regulations for the administration and monitoring of pediatric anesthesia and dentistry provide adequate protection for pediatric patients, make the report publicly available on the board's internet website, provide a report on pediatric deaths related to general anesthesia during the sunset review, as well as complete the board-approved, provide to licensees to complete a board-approved reporting form as incidents occur relating to general anesthesia or conscious sedation. So this bill mirrors essentially to Senator Hill's request. Senator Hill it was recently amended this week to include Senator Hill as a co-author, and one section was stricken out, which you should all have the amended form of the bill, which was relating to the penalty on licensees who fail to submit the required report. And so at this time, staff recommends that we continue with our support and concept position of this bill.
Any questions? Any further action? Thank you.
Okay. Next we have is AB 2331. In June, this bill was amended to specify that the ADEX exam itself would undergo the analysis as specified by Section 139, and the board would specify which exam format will actually be recognized in California. And then the acceptance of the ADEX exam will be given when it is determined to meet the exam requirements of the proposed bill. And so this, last I checked, was in its third hearing, or third reading. And so at this time, staff recommends that we take a support position on this bill. And if anybody would move a motion.
And this bill is currently located where?
It's in the Senate.
Okay. We do have someone representing the client on this bill here to answer questions, if you have any. Seeing nothing, thank you.
Did we want to take a position on this or continue? Because we had taken a watch position during the March and May meeting, and then did we want to maintain that watch position or continue with support?
Aaron, this is third reading?
It's on Senate third reading on the floor.
Okay.
So it's fine.
I'd like to move a watch position, I'm sorry, a support position on this bill. And also want to really compliment the staff on this for doing everything that we have asked to bring this bill around to something that we could support. So I'm going to move a watch on this. A support on this. Is there a second? Wu
Move for
second.
second, okay. Been a motion to take a support position and seconded that motion. Any discussion?
I'm sorry, I really haven't been able to track this issue as carefully as I would have liked. But are there, and I should probably ask this to the representative who's here, are there still unresolved issues regarding the type of exam that's going to be given?
No, I don't believe so. Aaron, could you?
Because I know there was some discussion about the Buffalo model and exactly how this would take shape. And I just want to be sure before we vote to support it that we know what we're getting.
No, that's an excellent question. Hi, I'm Erin Levi, representing ADEX. We've actually left the language, so it's up to you, the board, to determine the format, the exam format specifically, because things could change between now and then and different formats, so it's really up to the board. Thank you.
Thank you for that clarification. Appreciate it.
So the bill has been moved and seconded. May I ask you to call the roll?
Okay, we'll call a roll vote.
Dr. Morrow? Yes. Forsythe, yes. Fran Burton?
Yes.
Chappelle Ingram?
Yes.
Dawson? King?
Yes.
Lai? Yes. Lay?
Yes.
McKenzie?
Yes.
Stewart?
Yes.
Witcher?
Yes.
Wu?
Yes.
Motion carries.
The next
And-
bill,
So I know it's Friday. If you could, on Monday, get a letter to the authors, please.
the next bill we have is Assembly Bill 2485 by Assemblymember Miguel Santiago. And so today, checking, this bill has actually just passed the Senate floor. And so it's passed the Assembly, now it's passed the Senate. And so this bill has been amended 4 times since March 2016 board meeting, and the most recent version of the amendments were provided 8/15, so everybody should have a copy of this. Ultimately, in the amended form of this bill, it kind of opens up the applicant pool to those eligible for graduation at a dental program and those who have education loans without any timeframe eligibility requirements. Also, it provides disbursements in the amounts of $35,000 each year, Each disbursement is to be made 30 days from execution of the program agreement between the board and the qualified lender, and disbursements are to be made of of year 2 and 3 year funds within 30 days of months 13 and 25 of the recipient's participation in the program. And at this time, originally, before the most recent language was introduced, staff had concerns and was going to recommend a support if amended position. However, since the amended form has come out, they have addressed staff's concerns, and at this time, I would recommend for the board to take a support position on this bill.
Aaron. Brianna, sorry.
Hi, I'm Brianna Pittman with the California Dental Association, the sponsors of the bill. Just really want to thank the board and especially the staff for working with us on all of the technical amendments. The bill's gone through many changes. Just really appreciate the work, on this bill. And one of the things is there's now an urgency clause in the bill, which will allow you guys to promulgate any necessary regulations as soon as possible. So we're pleased that this will be going into law and that it just passed the Senate yesterday on a unanimous vote. So thank you.
Thank you for your work on this, too. So does it have to go back for concurrence?
Probably.
Fran, may I
Yes.
say something? Well, on behalf of the community clinics, I want to also thank the dental board, us, for supporting this bill. It's going to make my job a lot easier recruiting dentists to work for my clinic as we are expanding our program.
Okay, so I'd like to move a support. Is there a second? Second, Mackenzie. Any discussion? If you would call the roll, please.
Morrow? Forsythe, yes. Burton?
Yes.
Chappelle Ingram?
Yes.
Dawson? King?
Yes.
Lai? Lay? McKenzie?
Yes.
Stewart? Witcher? Wu? Motion carries.
The next bill we have is Assembly Bill 2859. Currently, it is in the Senate, and it's awaiting its third reading. This bill pertained to the retired license status option. Since the last board meeting, staff submitted to the author's office a letter of concern, and as a result, the bill was amended to include language that this proposed bill would not apply to the board that already have statutory authority to establish a retired license, and recently it was amended to require boards that are choosing to establish a retired category to establish an application fee to recover any costs associated with issuing the retired license. And so staff recommends taking a support position on this bill as it would provide the board the ability to establish license status for those who no longer want to practice dentistry nor renew their license.
I'd like to move a support.
I have a question. So I don't understand, I think we have in the dental board, we have an inactive, and we don't have a retired. So I'm not clear on what's the difference.
So for those who would like to maintain their license but not practice, so they can choose to go the inactive route. But then there are those who don't want to practice, they don't want to practice dentistry completely, and so the only option currently that they have is to not renew nor go inactive, and so they're kind of delinquent until 5 years when it's canceled. But with this, what they have now is with the ability for boards to create a retired category, which means that they're not practicing nor maintaining their license. And so it's just kind of a quicker way of getting a retired status as opposed to waiting 5 years until their license is deemed canceled.
Second.
Did you want to add something, Sarah? Okay. I'd like to move a support on this. In this case, I don't think we need a letter, but I would suggest a call to the author's office to thank him for taking our amendments. So it's been moved and seconded. Any questions? Public comment? Call for, yes.
And come on. Oh, yes, it does. Why is it that we don't need a letter or would recommend a letter rather than?
One, because of where the bill is now. So, and the time that it would take to get there, it really doesn't have any, it won't have any additional effect. But we do want to thank the author for making our changes. So,
Fran, I have a question. As the bill is written now, if I take a retired status on my license, at any time in the future, can I reactivate it? If I
So-
decide to come out of retirement for part-time or whatever?
So it does give you that ability for those who want to come out of retired status to start practicing, but that would require the board to develop, promulgate regulations to see what is the process that we would go and do. Because ultimately, whoever selects the retired status, you pay a one-time application or one-time fee, and then you're done, as opposed to those who are on inactive and they're paying biannually. And so there would have to be some kind of regulations established.
and if you recall, some time ago, we had a discussion, there was a strong feeling among some folks that they didn't want that to be in that retired. And on the other hand, some who didn't want to be inactive. So now we're covering all our bases.
Well, yeah, you can't please everybody, so we try, but we can't.
No.
Okay. But it is an option that's left open to come back out of a retired status and go back to active. That would be, I'm understanding that would be up to the board to promulgate regulations to allow that to happen.
Right.
Okay.
Sarah?
Just to clarify to Dr. Lai's question and Dr. Morrow's questions, so this would essentially add another license renewal category. And so what we currently have is the option for a licensee to go into the inactive status. That would require the biennial renewal to continue. The only requirement that would not need to be met is the continuing education requirement, because theoretically they're not practicing. We also have, it's not necessarily called the retired license status, although that's what it's referred to frequently. It's a reduced renewal amount that dentists have the option to have for their renewal. They have to be of age to receive Social Security and practice for nonprofit or not-for-profit predominantly through the year. And so there are a good population of dentists that choose to go that route, but they do need to still continue to have their continuing education units and continue the biennial renewal. So this would effectually give a dentist an option, if they're just retired out completely, to not have to renew biennially, and can maintain that retired status permanently.
CDA?
Gail Matthew, CDA, and if this isn't the right place to get this question answered, then we can do that other. So I'm trying to understand the difference between a choice for inactive and a choice for retired, if you can come out of both. In my own mind, that was the difference. You have inactive if you at some point want to come out, and you actually choose retired when you're retired and you don't plan to come back out. So I'm wondering if if you could clarify why there might be an option to come back out of retirement. Okay, thank you.
It's not predictable, but life changes sometimes. So, an individual might say, oh, well, I'm going to retire, and then something happens and their finances don't materialize the way they thought they were, so they at least need to contribute on a positive basis to their financial support. And that means they might go back into practice for part-time, or even I say I'm going to retire, But could I have a faculty position in a dental school in California with a retired license, or do I have to have an active license? I believe it requires an active license. So if I retired and then decided, hey, I'm getting bored with retirement and got an opportunity to be a faculty member at a dental school, could I do that? Could I reverse my retired status so that I could then be a faculty member in a dental school?
Understanding your question?
Yes, in my mind, up to this point in time, you could have done that if you had chosen inactive, but not, yes, so thank you, I appreciate it.
Thank
Yes.
Do we currently have in place under this retirement, if in fact they do come out of retirement, what they'll need, do we have those guidelines?
So that's something that would be established by the board when we promulgate regulations. And so that's when it comes up, then we would have to take that position and start implementing what is necessary, how can they come back, and what are the steps to come back.
So what I'm hearing is that your answer to that is, no, we don't have that at the present time, but it is something that we could develop or would develop in the future. Okay.
So kind of answering Gail's comment, then if we had a retired, we really don't need an inactive.
So I think some of the difference can be, like we were talking about yesterday, about how it takes 5 years to go from delinquent to inactive. So we have this high delinquency rate. This would at least allow people who are consciously deciding that they are retiring and they're not going to, it's one way. It wouldn't solve all of them. It wouldn't solve the people who've moved out, but at least it moves some of those up earlier.
Anything else? Did we take the vote on that? Okay.
Okay, we have a motion to support position on 2859. We're taking the vote. Dr. Morrow? Yes. Forsythe, yes. Burton?
Yes.
Chappelle Ingram? Yes. Dawson? King?
Yes.
Lai? Yes. Lay? Yes. McKenzie? Yes. Stewart? Witcher? Yes. Wu? Yes. Motion carries.
So the next bill we have is Senate Bill 482 by Senate Member Ricardo Lara. Currently, this bill is in the it's in the Assembly ordered for third reading. In amended form, this bill requires those who prescribe, administer, or furnish a controlled substance to consult with the Cures database to review patients' controlled substance history before prescribing for the first time. Then at least once every 4 months thereafter, they would have to check the system. Recent amendments require that if a healthcare practitioner authorized to prescribe a controlled substance that isn't required to check the Cures system because of an applicable exemption, then the first time, he or she must consult Cures before subsequently prescribing thereafter, once every 4 months. Also, Cures can't be checked earlier than 24 hours or the previous business day before prescribing, administering, et cetera, to the patient. It prohibits the prescriber in prescribing additional Schedule II or Schedule III controlled substances to a patient who already has an existing prescription until there's a legitimate need for it. And so at this time, staff was recommending that we take a watch position on this bill, but it's up for board discussion.
I'm not inclined at this point to do anything with this, unless someone feels otherwise.
What is the status of this bill now? Where is it on its path?
It's in the Assembly awaiting its third hearing, so it's already passed the Senate. It's waiting for the Assembly.
It's just right at that edge. And she had said that at the beginning. So unless someone feels otherwise,
Next bill we have is Senate Bill 1155 by Senate Member Morel. In 8/11, just last week, this bill was held in committee and under submission, and so it's no longer continuing on. And so at this time, there isn't a position for the board to take or choose to take. And then the next bill we have is Senate Bill 1348 by Senate Member Anthony Canella. This bill is already in the governor's office, and so it was requiring if the governing board authorizes veterans to apply military experience and training towards licensure requirements to post information on its internet website, advising veteran applicants about their ability to apply military experience and training towards their licensure requirements. I had recommended a support position on this bill. It's already at the governor's office, and so
I'm not inclined to do anything with this one either, unless someone has some strong feeling otherwise.
the next bill is Senate Bill 1444 by Senator Hertzberg. Recently, this bill was placed on the governor's desk also, and so if everybody would prefer, I can go and discuss more about this bill, which is, it was regarding the computerized personal information security plan that would detail the agency's strategy to respond to a security breach if there was one. And again, this is it passed Senate, it passed Assembly, and now it's at the governor's desk.
It's been my feeling that this bill is puts more of an onus on DCA than on the board. And so I'm not inclined to do anything with this one either.
And the next bill is Senate Bill 1478. It's the omnibus bill that makes technical non-substantive changes. We took a support position in pertinent part to what applied to the dental board in the May 2016 board meeting, and it was just to keep the board abreast of what's going on. And currently, it's been ordered to third reading in the Assembly. So there's no position or anything needed.
Thank you. 19C, update on pending regs.
So with the abandonment of applications, we finally submitted to OAL, and so we are waiting a response back on September 9th to determine whether it was approved or disapproved. And so if it gets approved, then it would become effective January 1, okay? And then the next regulatory package we have is the Dental Assisting Comprehensive Regulatory Proposal, which Leslie discussed yesterday. Currently, there are workshops that are being held to develop the dental assisting regulations. The next regulatory package we have is the elective facial cosmetic surgery permit application requirements. The EFCS committee was scheduled to meet on July 13. However, because no permit applications were received, the meeting was canceled. So the next committee meeting is scheduled on October 19th, at which time the committee will consider the proposed language and recommend to the board to proceed with the rulemaking. The next regulatory package we have is the licensure by credential application. Staff is still working on the regulatory language to present at a future board meeting. The continuing education requirements and basic life support equivalency standards. Again, board staff is working on the development of the proposed language, and it will be presented to the board for consideration at a future meeting. The mobile and portable dental unit registration requirements. During the March 2016 board meeting, the board approved the proposed regulatory language for the mobile dental clinic and portable dental unit registration requirements, and currently staff is drafting the initial rulemaking documents to submit to OAL. And then we have the dentistry and dental assisting licensing and permitting fees. Board staff filed the initial rulemaking documents with the Office of Administrative Law on June 14th. We initiated our 45-day public hearing comment period, which we'll discuss soon. And it was started January 24th and ended August 8th. And we received 2 written comments, which will be discussed. And the defining discovery and filing rulemaking package, We initiated the rulemaking file for this regulatory package. We submitted the initial rulemaking documents to OAL, and currently we are in the 45-day comment period.
D is discussion and possible action regarding fiscal year 2016-17 regulatory priorities.
If I just may interrupt, we have neglected to take public comment on any of the prior agenda items. So if anybody in the public would like to comment on 19A, B, and C at this point, you can come forward. Apologies. Thank you.
For 19D, the regulatory priorities, staff requests that the Dental Board of California set its priorities for the promulgation of new regulatory proposals for the duration of the year, so that staff may manage the workload associated with meeting the board's goals accordingly. And so listed 1 through 8 are current or prior 2015-2016 regulatory priorities. And then we've also added 9 through 11, which to be added to that list. And so staff recommends the board consider maintaining the same regulatory priorities it established in 2015-2016, and also adding rulemaking packages 9 through 11 to the new fiscal year.
Just for clarification, so in your original board packet, you received a memo that was 5 pages long, and this morning you received a one-pager. The only difference is the one-pager actually gives you the priorities 1 through 11. So she's essentially taken the recommendation that appears on page 5 of the initial item and just put them on one cover page. So you'll have 1 through 11.
And just so I understand, with the previous section, some of these are far enough along that they're going to come off this list pretty soon.
Yes.
The abandonment of application, yes.
Okay.
Yeah.
Any questions on this?
I may be missing something, but I just want to make sure our fee increase regulations are pretty high up on the list.
True.
Yeah, I guess this is a little misleading. These are the numbers, not, we're hoping to move everything up in this order, but we're working on a number of these at the same time. So abandonment of application will likely be off soon. Discovery and filing will likely be off soon. And of course, we are today are continuing with the fees, but absolutely, fee is number 1. So thank you for reminding us of that. In the event that board members didn't know, the fees are number 1. Is there confusion over here? Are we missing something?
It was
On your,
handed out.
it's just one
It was
page.
handed out.
It
It
says
was on the
agenda item
table.
19D.
You don't have the memo on top of those?
You have it? Okay. Sarah?
I think maybe we missed your discussion about whether it should be item number 7 while we were trying to look for it, so.
The discussion was that there are a number of things that are happening simultaneously. So it's not actually number 7. It's a priority.
Then maybe it should be worded differently, because it says the following are the rulemaking in priority order.
It's a mistake that staff made. We'll be sure to correct it in the future. These are all priority rulemakings at this point in time, and as Karen stated previously, we're currently working on all of them at the same time. A lot of them are in the preliminary rulemaking activity stages. A lot of them have already been promulgated, like our abandonment of applications, the fee increase, and then the statute of limitations to define filing and discovery. And so those that are going through the formal rulemaking process right now, we continue to track those. Those are our top priority, as well as also working simultaneously on all the rest. So it's a little bit deceiving. They're not necessarily all in priority order at this point in time.
However, at this time, if board members have, would like to reprioritize, if you will, or say that they prefer that something go above the fee increase or something go directly below the increase, the dental assisting comprehensive rulemaking is on the list as a high priority, but we've set these workshops going forward, so that will conclude when we've concluded that discussion. So as you see, a number of these things we are working on, sort of like there's 3 number ones, if you will. So, but this is an opportunity for board members if they want to emphasize a particular rulemaking going forward. It's an opportunity to discuss that now. Thank you.
I think I'm satisfied. Anybody else? Yes.
A question, if I'm understanding this right. When number 11 says minimum standards for infection control, with the CDC guidelines having been revised recently, should that be a priority for us to move up 11 a little bit higher? Well, not that it's on the bottom of the list, but make that more of a priority?
Maybe I know too much, but what I know is that staff is working on a number of pieces that are in various stages of development. If it's confusing to anybody that this says 1 through 11, I think that we have acknowledged that perhaps that wasn't the best way to state it. But these are all works in progress. And going back to the question that I asked earlier, just so that it could be clarified to everyone, the section before, a lot of these things are well on their way. So 11 really doesn't mean 11.
Okay, I'm good. 11 doesn't mean 11. I'm good.
I'll just reiterate, you have 11 number ones.
All right, I'm good.
You have 11 number ones. Dr. Stewart, that we work with a hygiene committee to update the infection control standards, and so as Noelle said in her comments today, we have an ongoing list going of changes that need to be made, and so we're noticing you that we're here, we've seen the CDC recommendations, and we're going to be moving forward. So we have 11 number ones.
Thank you.
I would just add, because on face value, some are around safety, and so if they look like a priority list and the names sound kind of safety related, it's the visuals of it, maybe.
So we would still need a motion from the board to accept the list as the priority for
So
fiscal year
moved.
16, 17.
Dr. Morrow?
Yes.
Forsythe, yes. Burton?
Yes.
Chappelle Ingram?
Yes.
Dawson? King?
Yes.
Lai? Lay? McKenzie? Stewart? Witcher? Wu? Motion carries.
Okay, the next item, which is 19E, is a standing item on the agenda for any stakeholders or board members who have ideas or concepts for consideration for prospective legislative proposals to bring forward. Is there anything that board members would like to put on this list? Stakeholders? Seeing none, thank you. Item 20 is the discussion on the we're doing 20A now, is the item on the fee increase.
At its May 2016 meeting, the dental board approved the proposed regulatory language relative to the fee increase, and staff on June 14th submitted the initial rulemaking documents to OAL, and the rulemaking so they were filed with OAL, and the 45-day public comment period began on Friday, June 24th, and it ended Monday, August 8th. During the regulatory hearing, no comments were received. However, the board did receive written comments from the California Dental Association and a joint letter from the Foundation for Allied Dental Education, the California Association of Dental Assisting Teachers, the California Dental Assistants Association, and the Extended Functions Dental Assistant Association. And so what we've done in the packet is divided into two, one letter from CDA, and then the second letter from the Dental Assisting Associations. And the California Dental Association expressed a concern regarding the fictitious name permit renewal, and as a response to their concern, staff recommends that the board accept CDA's comment to establish the fee for a fictitious name permit renewal at $325. It should have been $325. That was an error on our part.
We had this discussion yesterday, already voted on it, so we can move on.
Oh, okay. And so the second part was regarding the dental assisting regulations, or the letter. And so, so we received the joint letter regarding the fee increase, and they commented that the increases to the program and courses application fees can potentially support the registered dental assistant and registered dental assistant extended functions examinations more effectively, rather than increasing licensing and permitting fees of the RDA and RDAEF licensees. And they also commented that the regulatory language be consistent between sections 1021 and 1022 relating to various terms, and that the recent statutory changes provide the board the authority to revisit programs and courses, proposing that a structure be placed into regulations that would allow the board to charge for a site visit fee for every 7 years. So KDAD, FADE, CDAA, and EFDAA recommended the addition of the word fee and other grammatical amendments throughout section 1021. And they recommended adopting a law and ethics re-examination fee, as well as a $120 fee for the issuance of a replacement pocket license or a replacement wall certificate. As a response, staff recommends that the recommendations to section 1021 be rejected because rationale and justifications are necessary for each proposed amendment. The recommended amendments to the language of the text are unnecessary, as the heading of section 1021 references that the subsections refer to fees as relating to dentists. Also, no rationale is provided as to why there should be a law and ethics re-examination fee, as well as why it should be $100. It would be duplicative to have the candidate reapply for eligibility through the board, since the board has already determined that the applicant or the candidate is eligible during their initial route to sit for the law and ethics exam. And also, there's no rationale or justification provided as to why the replacement pocket license fee should be $125. And so should the board make an action to accept, reject, or modify staff's recommended response to the comments, there would need to the board would need to provide a rationale for inclusion or exclusion of that, of their decision.
Just a question. I mean, doesn't the staff report give justification for rejection?
It does. So if the board accepted staff's recommendation to reject the comment in the joint letter, then no additional rationale would be necessary. However, if the board decided to reject staff's comment, we would ask that you would provide additional rationale or justification to be included in the rulemaking file.
Claudia Pohl, California Dental Assistants Association. So while we understand that there was rationale lacking for each individual item, and we understand that the programs and courses will be dealt with in regulatory, is that correct? Which we did not understand, so we'll deal with that then. But we would just like the consideration given for the stark increase for both renewals and for the RDA application, that there's a hefty increase and perhaps a step up over a period of time as opposed to such a large jump in increase, because it's going to be a hardship, and so there you go.
Just to clarify what Ms. Pohl was commenting on, KDAD, FADE, and CDAA did propose fees for the reevaluation of RDA programs. That is something that we are looking into as part of the Dental Assistant Comprehensive Rulemaking Package. We're not ready to make that proposal at this time because we would need to conduct a workload analysis, so that it could be a proposal forthcoming.
Hi, my name is Gina Macias. I'm actually here more representing my students. I'm a program chair and teacher at a school in a severely economically challenged location. And I would recommend that the board really consider the amount that they raise these fees. Some of my students that are graduating from my program are barely making minimum wage when they graduate and are paying back their student loans, which those of you who are dentists knows how much student loans are. So I see it being a huge economic impact on their lives and whether they can get licensed and whether they are renewing their license in addition with the continuing education. So I would request that you take that into consideration before you make any adoptions of raising fees and renewals.
Anything else? So the staff recommendation, if you would repeat it again, please?
Staff's recommendation relating to section 1021 is to reject the recommendations provided, which is different from section 1022, which
Okay.
we'll be talking about.
And so let's take this in two parts. And so the recommendation is to reject the comments related to section 1021. Is there a motion? I'm sorry. Late. Okay. And I'll second. Discussion? Just call the roll, please.
So the section 1021, maybe, this is the section, remind me the difference between the two.
So 1021 is
Okay.
relating to dentists, and 1022 is relating to dental assistants.
Thank you.
And if you look at the packet, it's spelled out here.
Yeah, it is
Okay.
here too, but. Thanks.
Okay.
Morrow?
Yes.
Forsythe, yes. Burton?
Yes.
Chappelle Ingram? Dawson? King?
Yes.
Lai? Lay? McKenzie? Stewart? Witcher? Wu? Motion carries.
So for the second part, which is relating to the dental assistants fees, Section 1022, the Dental Assisting Associations recommended technical grammatical changes to the heading of this section, the language proposed in the body of the rulemaking, or in the proposed language, as well as the adoption of footnotes for consistency with Section 1021, amendments to proposed fees, and adoption of various other fees. And so it's listed in the letter as well as in the memo of all the fees that staff has recommended and what the dental assistant associations are recommending that you can use for comparison. But staff recommends, as a response to their comments, that the board reject the recommendations, because if the board averts or delays an immediate fee increase, the board's state dental assisting fund will become insolvent, and the structural imbalance between its revenue and expenditures will continue to grow. Staff acknowledges the concern relating to the program and the course application fees. However, as Sarah said, as we've kind of discussed, the application fees for the RDA and RDAEF programs and courses are part of the comprehensive dental assisting regulatory workshop, which will be discussed then so that we can do further research, look at workloads, and so forth.
Board discussion? Public comment?
I think when Bruce and I also worked on this, we were concerned about the rate increase we felt we needed to do, because we know it is very hard on all that will have to accept this, but we didn't find any easy other solution. So I do want to say it, everyone has our empathy, but, and if we could have found another way, we would have, I think is the main thing, right, Bruce?
Yeah, the actual recommended fee increase was larger. And so we kept it as low. I mean, we're very sympathetic, but unfortunately, renewal fees are the #1 revenue raiser for the program.
At this point, I can interject that should the time come that program fees are increased to a level that would assist these in the fund being more robust, there is an opportunity to actually reduce fees. It rarely happens, but if something should change moving forward, that certainly would be an option. I know that it's a concern among board members, but at this point, we're between a rock and a hard place in order to keep the program, licensure program going. And so unfortunately, that's where we are at this point.
Okay, so is everybody clear on the motion? You have the motion? Oh, no, you don't have a motion. I'm going to move that we reject the comments related to fees. Yes, in section 1022. Second, McKenzie.
Okay, call for vote. Morrow?
Yes.
Forsythe, yes. Burton?
Yes.
Chappelle Ingram? Dawson? King?
Yes.
Lai? Lay? McKenzie? Stewart? Witcher? Wu? Motion carries.
The next step would be for motion to be made to modify the text in response to the comments received from the California Dental Association, and direct staff to take all steps necessary to complete the rulemaking process, including preparing the modified text for a 15-day public comment period, which includes
Spencer, sorry. We have two more staff recommended modifications.
Oh, I'm sorry. Okay. I'll pick up from where I left off.
So staff recommends to modifying the section 1021C. So during the May 2016 board meeting, members of the board expressed concern relating to the $800 cost of the examination, the portfolio examination pathway. And so we took that back and conducted research regarding the pathway, considering the number of applicants, the costs associated with implementation, the costs associated with implementing the similar pathways, and staff recommends that the fee be modified to $400. So
Staff is recommending that the fee be modified from $800 to $400.
Is everybody clear on this?
No, I don't.
Okay. At the May board meeting, we brought forward staff recommendations, the subcommittee recommendations for all of the fees that were outlined, and the board adopted the language. At that point in time, we had conducted all of the fund condition analysis to determine that the fees that were brought forward at the May board meeting would sustain our funds. After the language was adopted, the board had expressed concern at the amount of the fee for the portfolio examination. At that time, we recommended moving forward with the promulgation of the regulation, and that staff could conduct more research to see if a $400 fee would sustain the fund, if it would make that much of a difference. And so we took that information back, and while the regulation was going through the rulemaking process and the 45-day comment process, we did an analysis of our fund condition and determined that $400 would be sufficient to sustain our expenditures on our fund. So at this point in time, staff is recommending that the board consider modifying the text to reduce the proposed fee for the portfolio examination from $800 to $400, and that would be included as part of the modified text.
Any comments? And so the short of it is, the motion is to modify the text to reduce the fee for portfolio to $400 from the previous $800. And I'm going to move that. Second, Lai. Any public comment? And call for the vote.
There we go. Morrow? Forsythe, yes. Burton? Yes. Chappelle Ingram? Yes. Dawson? King?
Yes.
Lai? Lay? McKenzie? Stewart? Witcher? Wu? Motion carries.
So the next staff recommendation we have is for, so there's a typo, it should say modify section 1021, not 1022, Q and R. And so staff, or the board again expressed concerns during the May 2016 board meeting regarding the fees proposed for the oral conscious sedation permit application, and suggested that further research be conducted to determine whether the proposed fee could be modified. Staff, again, consider the complexity of all the permits, the current cost of the recommendations from the board subcommittee, the recommendations from capital accounting partners, and staff determined that the oral conscious sedation permit be modified to $368 for initial application for the permit and $168 for the renewal of the permit.
Did we vote on this one yesterday?
No.
No? Okay. For some reason, I thought we did.
So staff was requesting a board motion to accept staff's recommendation.
I'll move. I'll second.
Okay, we're going to call the vote. Morrow? Forsythe, yes. Burton? Chappelle Ingram? Dawson? King?
Yes.
Lay? McKenzie? Stewart? Witcher? And Wu. Motion carries.
So in follow-up to that, after we've considered all of the comments, the last piece of action would be to adopt the modified text. So staff is requesting that the board make a motion to modify the text in response to the comments received and the modifications recommended by staff, and direct staff to take all steps necessary to complete the rulemaking process, including preparing the modified text for a 15-day public comment period, which includes the amendments accepted by the board at this meeting. If after the 15-day public comment period, no adverse comments are received, authorize the executive officer to make any non-substantive changes to the proposed regulations before completing the rulemaking process, and adopt the proposed amendments to California Code of Regulations, Title 16, Sections 1021 and 1022, relevant to the dentistry and dental assisting fee increase as noticed in the modified text.
Any discussion? So the motion is to adopt the modified text and take the steps necessary to complete the process. We're going to move. Public comment. Call for the vote.
Morrow?
Yes.
Forsythe, yes. Burton?
Yes.
Chappelle Ingram?
Yes.
Dawson? King?
Yes.
Lay? McKenzie? Stewart? Witcher? Wu. Motion carries.
Didn't we have an item from yesterday?
I think that we did that.
Can I just ask, Steve, did we do that item from yesterday that we moved on to today?
That's the one that we just did. Uh-huh.
Thank you. Maureen Titus, California Dental Hygienists Association. What I'm just doing is a gentle reminder. April 21st, we sent a letter to the board regarding corporations, and then we also had this brought up at the May meeting. So I just don't want it to be lost and forgotten. I'd like it to get on your agenda at some point. Dental corporations, you cannot find on your website, which I understand they register with the corporation, the Department of Corporations, not the dental board. If a consumer wants to find out about the dentist who work for a specific corporation, they can't find out any information at all, and I have looked also. So there's different corporations, mobile dentistry, that a lot of people are wondering about, and we've had complaints, I guess you could say complaints, concerns, to our association, and we don't know how to recommend any handling of this. So since the dental board obviously licenses, and if everything is sort of wrapped up in this dental corporation, and you don't know who these dentists are, the consumer doesn't have any transparency. They don't have a clue who these dentists are. They don't know if there's any actions against them. They don't know anything about them. So I'm not sure how to solve the dilemma, whether the corporations have to report to you. I know that there was a bill put together about 3 years ago, I believe it was 562 Senate bill, and it had to do with mobile dentistry. So if there's something that this board can put together, have a discussion about how to make it more open and transparent for consumers to find out who the dentists are that they're going to go see.
Hi, Brianna with CDA. Just wanted to give a couple of just kind of updates, just FYIs. We will be having our CDA Cares event, which is the dental clinic, serves about, I think, 2,000 people over 2 days. It's coming up in Stockton on October 15th and 16th. This is a biannual event that we do sort of throughout the state, in varying places twice a year. And so if you are interested in coming and attending, we're going to be doing tours on Saturday, October 15th. Connect with myself or Gail, and we would be happy to set up a tour of the clinic for you guys. Also wanted to let you know that at CDA Presents, which is our trade show educational opportunity, as we have in the past, we will be doing a course on pain management, opioid reduction, and use of the cures system. So we continue to do more education on that issue. And then there were two pieces of legislation that I noticed weren't on your list, but I thought might be of interest to the board. The first one is AB 2207, which is a Denti-Cal streamlining bill by Assemblymember Dr. Jim Wood, and it's really just looking at reducing some of the administrative burdens on the program, streamlining provider enrollment, and also doing a significant amount of data collection and tracking on the DTI initiative that you heard about yesterday from Dr. Kumar. So we're very excited that we will be having, hopefully if the bill passes, we will have a lot of data on the work that's being done there and really seeing how outcomes have changed as a result of those the components of the DTI, excuse me. The last bill was AB 2744, which is a bill by Rich Gordon, Assembly member, and it's a Groupon sponsored bill. So this deals with the issue that I know has been before you in the past around whether or not the use of a social coupon is in fact a referral, which is banned in the BNP code. And so this bill is creating a exemption that clarifies that it's not and putting some protections around both for the provider and for the consumer. So it's a bill that CDA has worked on. We've gone neutral on the bill. And just want to let you know that that issue is being looked at in the legislature because I know it's been before you. Thank you.
Any other public comments? Okay, seeing none. Item 23, board member comments, items not on the agenda.
Do we have an update on the RDA exam manual?
Well, as a matter of fact, thank you for asking. Because we need to recall the EO report. If the president will recall the EO report?
Yes.
So I neglected to say, even though it's written in my EO report, that based on the recommendations the board gave and the direction that the board gave in May for OPES to work with staff to come up with a RDA practical candidate handbook, OPES did that, and it's been distributed to candidates for the upcoming exam as well to program directors. It's available on our website. And this all occurred around the 15th, which I think was this week at some point, August 15th. So Linda will be passing out a copy of the RDA Practical Candidate Guide, which does include the rubrics that the dental assistants were asking for. And thank you for bringing that up.
Since that was a comment that was on the agenda, do we have any comments that are not on the agenda? Okay. With that said, I think that I want to thank you all for having such a successful board meeting. I think we've conducted a lot of important business over the last couple of days. I hope you all have a safe journey home and a fantastic weekend. And looking forward to meeting together again with all of you in the near future. Okay? Thank you very much.